Okay, guys, so let's go over our objectives first. Okay, so we'll begin, inshallah, by talking about basic anatomy and terminology. And then we'll be talking about body systems, like, for example, muscles, bones, joints, cardiovascular, and nervous system. And then we'll talk about general histology, which is, epithelium, connective tissue, and etc. And then we'll move on to hematologic morphology and disease, which is like neutrophils, eosinophils, and etc. And then we'll finally end it with lymphatics. And keep on, inshallah, keep with us, because we'll be asking you questions throughout the session, inshallah.
Okay, so our first objective is basic anatomy and terminology. This is going to be really easy, and it's going to be quite quick too. So first things first, anatomical position. Your anatomical position is the body should be erect, okay? Your arms should be supinated, so the palms are facing forwards, or if you're lying down, the palms should be facing upwards. And your feet should be together, and the thumbs are pointing to the sides. As you guys can see here in the picture, the palms are facing forward, the body is erect, feet together, and thumbs outwards, okay? Or laterally to the side. Okay, now we'll start with the body sections, okay? So the first section that we have is the sagittal section. Sagittal section splits your body into left or right, okay? Mid-sagittal splits them into exact equal halves, okay? So the left half is equal to the right half. And this is called the mid-sagittal plane or the median plane. And then we have the parasagittal, which can be anywhere, but it's still splitting the body into left and right. So can you guys see this plane here? It's called sagittal or parasagittal. So the two parts are not equal. Then we have the frontal or coronal plane, which splits the body into two halves, front and back. Okay, again, it doesn't have to be equal halves. Front means anterior, back means posterior. So this is the anterior half, and the one at the back is the posterior half. Okay, so this is your coronal or frontal plane. Next up, we have the transverse section or the transverse plane. Transverse means it crosses the body, okay? It's also called axial plane, okay? And it splits the body into up and down, which is superior and inferior, okay? Then, for some reason, I saw this in your slides. We never took this, but you should know it. It's called oblique plane. So it cuts your body at an angle, okay? Or diagonally, okay? Next up, we have the directional terminology. But before that, do you guys have any questions? All right, no questions. So the static directional terminology, we have superior, which means up, okay? Inferior, which means down, okay? Now, if I say your head is superior to your chest, that means it's above your chest. So it's at the top and your chest is below it, okay? And the chest is inferior to your head, okay? So it's below the head. And then we have anterior, which means front, and posterior, which means back, okay? Anterior is also called ventral. Posterior is also called dorsal, okay? And then we have lateral, so to the sides, whether it be left or right. So either side is fine, it's still called lateral. And medial means towards the middle, okay? So your nose is medial, however, your eyes are lateral, okay? Then proximal means near the origin, and distal means far from the origin. Now, what does this mean? I'll give you guys an example. Your arm, the origin of the arm is the shoulder, okay? Now, if I say the elbow is proximal to the wrist, that means the elbow is closer to your shoulder, which is the origin of the arm, than your wrist, okay? And your wrist is distal to your elbow. So that means from the origin, which is the shoulder, the elbow is closer and the wrist is further away. So proximal, closer, distal, further away. Okay, so near the origin is proximal. Further away from the origin is distal. Okay. And then we have the movements. So flexion, this one is easy. Decreasing the angle of the joint. Now, when you flex your arms, okay, can you guys see this angle here? It's getting smaller and smaller. Can you guys see me? Okay, so the angle keeps on decreasing when you flex. However, when you extension, the joint's angle increases. Okay. So look here in the picture. When she flexes her leg, the angle here decreases. When she extends it, the angle increases. Same thing with the arm. When she flexes it at the shoulder, can you guys see this angle? It gets smaller. However, when she extends it backwards, the angle becomes really big. Okay, so increasing the joint's angle is extension, decreasing the angle is flexion. Then we have abduction. Okay, this is supposed to be here, adduction. Okay, no worries, we'll fix this later. But abduction means raising your arm or your leg upwards laterally to the side. Okay, so you're abducting. To abduct means to take away. Okay, so you're taking your arm away from your body. The second one, which is supposed to be adduction here, adduction, you're bringing your arm or your leg towards your body, towards the median line. Okay, and we said the median line is what? The exact line in the middle. Okay, so when you adduct, you're adding your arm or your leg to your body. So adduction. So you're bringing it closer to your body. Okay. And then we have circumduction. Now, circumduction is a mix of all abduction, adduction, flexion, and extension to move your arm in a circle. Okay. Now, can you guys see here? He's moving his arm in a circle. And to do that, he's abducting and adducting, also flexing and extending at the same time. Okay. So in a circle, from their name, circle, circumduction. And then we have rotation, okay? And then there are two types of rotation in your limbs. One is called external rotation, one is called internal rotation. External rotation towards the outer side, okay? Or lateral. And internal rotation towards the middle or medial side, okay? So can you guys see here in the picture? She's rotating her leg externally to the side, laterally. And internal rotation, it's toward the median or internal. This is called internal rotation. Okay. Now, these two movements happen only at the foot. Okay. So when you flex your foot upwards towards your body, that is called dorsiflexion. Okay. And when you like flex your toes and like point them, just like how you know how ballerinas stand on their tippy toes, that is called plantar flexion. Okay. So pointing your toes downwards away from your body, that is plantar flexion. Towards your body or upwards, it's called dorsiflexion. Okay. Now, these two names are because this side of the foot is called the dorsum of the foot. This side of the foot is called the plantar side of the foot. But you don't have to know that. This is plantar flexion. This is dorsiflexion. Okay. And then we have also these two are in the foot. Inversion towards the medial side because so towards the middle, okay, or inwards. And then eversion, turning your foot to the side or outwards. So eversion, out, inversion, in, okay? This one is towards the median. This one is towards the lateral side. Then we have this movement called supination. Okay, so your hands, your palms are facing upwards if you're standing up, or if you're lying down, if your arms are straight down, like I showed you guys in the anatomical position, it's going to be towards the front. However, if you raise your arm, it's going to be upwards. Okay, so upwards or forwards are both called what? Supination. Okay, so upwards is, think of it like you're holding a bowl of soup. And then pronation, you're pouring the bowl of soup. Okay, so pronation is downwards, supination is upwards. Okay, now a quick note, guys. Supination is not the same as supine. Supine means you're laying on your back. Okay, so flat on your back, that is supine. Supination is rotating your arm so that your palms are what? Facing upwards. Okay. And then, of course, pronation is downwards. Okay, so question. Which image shows the type of plane that can separate the left and right eye? Okay, and what is it called? Okay, I see people saying sagittal. Sagittal is not specific enough. You have to say the full answer. It's called, yes, mid-sagittal, exactly. Okay, so if you just say sagittal, it's going to be counted as wrong because it's exactly in the middle. Okay, so it's called mid-sagittal. You guys have to be careful with that. Okay, so do you guys have any questions? Okay, so all clear.
Okay, hello guys. So now that we've talked all about like the simple anatomy, okay, now let's dive deep into the actual anatomy. So we're going to talk about body systems, okay? And first of all, we'll start with the MSK system. And the first thing we'll talk about is muscles. So muscles. There are 5 types of muscles, okay? The first type is parallel. Second would be fusiform, triangular convergent, oblique, and circular. Now we have all of these types of muscles, but what differentiates from each of them is the way that the fibers are going. So we'll see like right now, like throughout each one, how different the fibers are. So parallel. Parallel means that the fibers are parallel and the fascicles run longitudinally along the muscle. Now, what does this mean? Here's a muscle, okay, and the fibers over here are running like along this muscle, like they're not crisscrossing and they're not, they're just straight, okay? And as you can see, like the tendon is as thick as the muscle itself. That's really important, okay? The tendon is as thick as this muscle itself, and the tendons are also flat. And a really famous example is sternocleidomastoid, which is a muscle over here that is in your neck, and your sartorius, which runs along your thigh. Sternocleidomastoid, by the way, it comes a lot in exams, so please remember this muscle, its name, and the fibers, like the fact that it's parallel. Now, what about fusiform? Fusiform, the fibers are also parallel, but what differentiates fusiform from parallel? It's the fact that the muscle belly is thicker in the middle. What does that mean? So here's our muscle. The muscle belly, which is in the middle, is thicker than the actual tendon. So the tendon is smaller in diameter compared to the muscle belly. And a really good example would be a biceps brachii. Biceps, as you can see, the tendon is very small compared to the actual muscle, and it looks spindle-shaped kind of, you know? And also your digastric muscle, which is right next to your sternocleidomastoid. Your digastric muscle is also a fusiform muscle. Okay, now triangular and convergent. From the name, convergent means joining together. So the fascicles, they're like distributed over like a broad area, and then they all join together at one single thick tendon. And this is how it looks like. So you have all your fascicles and your fibers, they all join towards this one single thick tendon. And there's only one example, and it's pectoralis major. Pectoralis major, pectoralis major. It's the only example, and there's a bunch of pictures. So I'm very sure that they're going to get this, inshallah, in your exam. It's a very easy muscle. It's triangular convergent. So it's, yeah. Okay, now oblique. Oblique, the word oblique means diagonal. So the fascicles or the fibers would run diagonally to its tendon. And we have 3 types of oblique muscles. We have unipennate, bipennate, and multipennate. Now, unipennate looks like this. So it basically, it's like convergent, but it's not because it's not triangular, okay? The fibers are running obliquely, they're running diagonally, and they're all joined towards one single tendon. And this would be your flexor pollicis longus, which is somewhere over here, okay? It flexes your thumb. And your extensor digitorum longus, which extends your index finger. So your flexor pulsus longus and your extensor digitorum, as you can see, they're both unipennate. They're oblique and they join towards a single fiber. Okay, what about bipennate? Bipennate, you have muscles on you have muscle fibers on opposite sides. So let's say this is your tendon. I hope you can see me. This is your tendon, and then you have muscles joining here, and then you have muscles joining this way. So yeah, that's bipennate. And it's really easy to memorize. And a uni means one, so it's just going to be one muscle. Bipennate means two, so it's going to be two muscles. And an example of this would be rectus femoris. Rectus femoris is a muscle on your thigh. So as you can see, it's converging into one from opposite sides. What about multipennate? Now, multipennate, what I like to think about it, it's like multiple or groups of bipennates all converging into one single tendon. So you have literally, it's more than one, obviously, and it's just groups of bipennates merging into one singular tendon. And there's only one example of this, and it's your deltoid muscle, and that's your shoulder muscle. And deltoid also came up in our exam, I'm pretty sure, or it came up in 16th batch, so I would take care of this as well. Okay, circular are basically fibers that are arranged in a circular arrangement to form a sphincter. Okay, a sphincter is like something that opens and closes in your body to allow certain things to pass through. And they surround an orifice. An orifice is just an opening, and it controls the closure. So, like your orbicularis oculi, this is the muscle around your eye that allows your eye to open and close. And you also have your orbicularis oris, which is around your mouth, which allows your mouth to open and close. So what's really nice about this, and they both start with orbicularis. So you just literally have to memorize oculi, oris, and yeah. So we're done with muscles. Do you guys have any questions? Extensor digitorum longus and the leg. There's both. There's one in the fingers, and there's one in the leg as well. Both, like your toes and your fingers. Yes, guys. For every single muscle, I included all examples that are in your slides, and these examples you need to memorize them because they can tell you what type of a muscle is it, and also name the muscle that is shown in the picture. So memorize the muscles and the pictures, please. Oblique, okay, sure. Do you want me to repeat oblique? Repeat it? Okay, for high yields, sternocleidomastoid is very high yield, and deltoid and rectus femoris, but all of them literally are important. Okay, so oblique. Oblique basically means إنه let me explain here, okay? First of all, you have three categories, but let me explain on unipennate. You can see the fibers here, they're running diagonally. They're not going straight. Like parallel is going straight. Convergent is going from all sides, but oblique is all going from a diagonal direction, okay? And this is the examples for it. And there's also bipennate. Bipennate, it's also diagonal, but you have muscle fibers on both sides of the tendon. And this is an example for it, which is rectus femoris. And multipennate is literally bipennate times 3, for example, or times 4, or it depends on the muscle itself. So you have fibers running diagonally, okay, on both sides, converging towards a single tendon, and you have multiple of those, and all of those converge towards one single thick tendon, like the deltoid muscle. I hope that's clear. Okay, inshallah, you'll get to histo soon. But for all of OSPE, by the way, they get the same exact pictures in your slides, either in your lecture slides or in your lab slides, usually always in the lab slides. So yeah, there's no way, inshallah, 90% chance they can't go out of the slides. They never have done that. Okay, I hope inshallah we can move on to joints. Okay. Now for joints, we'll start with the fibrous joint, okay? Fibrous joint is basically tough fibrous tissue which holds the bones together, okay? So for example, sutures. Sutures are these joints in your skull. Believe it or not, your skull is actually made up of multiple bones. It's not just one bone. And what connects these bones together are something called sutures. And yeah, and also mention that I said here synarthrosis. Synarthrosis is the functional classification of this joint. Synarthrosis means that this joint is immovable. It can't move. Like right now, if you try to move your skull, you won't be able to move the bones against each other. It's just immovable, okay? It's a fixed joint. Okay, and then we have syndesmosis. Syndesmosis is basically like the cartilage or like the joint that is between two bones, okay? And usually like the bone would wrap around another bone. So how do I explain this? Your radius and ulna. طيب. In your arm, you have two bones called radius and ulna. طيب. I want you guys, like right now, if you can, put your arm on a table or anything, or like just hold your arm like this and just pronate or supinate your arm. Supinate and pronate your arm. You can move, you can like feel your bones moving. Why can you feel your bones moving? It's because of this joint, syndesmosis, okay? And since we can feel our bones slightly move, it doesn't move freely, of course. We call this amphiarthrosis. It's slightly movable, okay? But the joint name is called syndesmosis, between the radius and the ulna, and you can also find this between your tibia and your fibula in the leg. And you also have gomphoses. Gomphoses are basically your teeth gums, okay? Your teeth gums, you can't move them, whatever. So it's fibrous joint. Okay, what about cartilaginous joint? Okay, cartilaginous joint, you have two types. You have primary and you have secondary. First, let's talk about primary. Primary is called synchondrosis, okay? Synchondrosis basically means cartilage together. Bones that are held by cartilage together. What type of cartilage? Hyaline cartilage. So usually they are immovable. They're also in synarthrosis, usually, okay? And they're always connected with hyaline cartilage. So guys, when you see hyaline cartilage, think primary cartilaginous and think synchondrosis. An example of this would be your diaphysis and your epiphysis of a growing long bone. So when you're a child, okay, your bones are still growing, صح? And that means that your bones are still, they did not ossify yet. They're not fully hard yet. So your diaphysis, which is like along the shaft, okay, it's kind of there's like a bit of cartilage. And your epiphysis, which is at the tip, okay, there's also a bit of cartilage. And this cartilage should be immovable. Otherwise, you'd of course separate your bone, which you don't want that. So it's synarthrosis, synchondrosis. What about secondary cartilaginous? We have symphysis. Now, symphysis is connected with fibrocartilage, and fibrocartilage basically makes your bones slightly move. And what did we say slightly move mean? That means amphiarthrosis. Okay, an example of this would be pubic symphysis. Between the vertebral bodies. So these joints that are right over here, why can we bend our back and like move side to side and everything? It's because of this fibrocartilage. It allows us to slightly move. And your pubic symphysis also is also like has fibrocartilage. So I hope you guys got this. This is a very important slide as well. Also, one thing I want you guys to keep in mind, when they ask for what type of joint or what structural joint, what's the structural classification, you think of fibrous, you think of cartilaginous, you think of synovial. When they say what is the functional classification of this joint, you think of amphiarthrosis, you think of synarthrosis. This is very important to differentiate. They always get this question, okay? Now, our last type of joint is synovial joint. And synovial joint, honestly, is one of my favorites because it's the easiest. It's basically the presence of a fluid-filled joint cavity. And this allows the joint to move freely. And what do we call joints moving freely? We call this diarthrosis, okay? So every synovial joint is diarthrosis. Now we have many synovial joints, as you can see here, but we're gonna go through them one by one. Let's start with the easiest, which is ball and socket joint, which is multi-axial. Multi-axial means that the joint allows movements in all type of directions, circumduction, abduction, adduction, everything, okay? It can go everywhere. So we have the hip joint and we have the shoulder joint. Of course, your shoulder can move it however you want it, you do it, and it's a ball and socket joint, which you can see here. It's like a ball and it, goes into a socket. Then you have condyloid ellipsoid joints, which is biaxial. Biaxial means that the joint only allows movement in two axes. So, for example, you have your radiocarpal joint. Your radiocarpal joint, which is over here. This is your radius somewhere over here, and then you have your carpals, which is in your hand. So the radiocarpal joint is a biaxial joint. You could do this, and you could go back, or you could go side to side. So you have two axes to work with. And you also have your metacarpophalangeal joints. Let me break down the word. It's a long word, I know. Metacarpal is right above the carpals, which is right over here. Okay, your metacarpals. Phalangeal means your finger. So your metacarpal phalangeal joint, which is AKA your knuckles. Your knuckles also has like limited movement. This is flexion extension is like its easiest one. And it can slightly do, like it can do abduction and adduction. So biaxial. Hope you guys got that. And this is how a condyloid looks like. It's like something that glides over another surface. Okay, what about saddle? Saddle is also biaxial joint. Now this one, I'm very sure this is high yield because listen, in medicine, anything that is an exception, it always shows up in the exam, whether MCQ, SAQ, or OSPE. Everything that's an exception, it always shows up. And the thumb, your first carpometacarpal joint, the thumb is an exception to being ellipsoid. We said that all the fingers, your knuckles, they're all condyloid, right? But your thumb is the only one that's saddle. And how can you remember this? طيب, your thumb, compared to your other fingers, it has the most movement. So logically, you would think, oh, it has a different joint. And then you just have to memorize it's a saddle joint. So saddle joint, it just looks like a horse saddle and something that glides on top of it. It's also biaxial. Okay, what about pivot? Pivot joint is uniaxial. It only allows movement in one direction. Okay, you have your proximal and your distal radio-ulnar joint. Proximal means close to your body. Distal means like away from your body. Radio-ulnar joint is what we talked about. Radius and ulna over here. Okay, what's it called? There's a joint over here and there's a joint over there. That's pivot joint. And remember when I told you guys, like when you move your arm like this and you can feel it move, this is the only like axis that it can move in. It's just wrapping around it. And you also have your atlantoaxial joint. Your atlantoaxial joint is somewhere like up here in your neck, okay? And it allows this movement, like saying no, like when you shake your head no, this is the only movement that it can allow. And where is the pivot joint? Yes, the pivot joint, as you can see, there's an axis in the middle and you have something that wraps around it, either a bone or either like ligaments. It's just like a ring that wraps around it. Okay, your plane joint is non-axial. It does not allow movements in any direction. طيب, it's just gliding. It's just like this, and it just glides along each other. So you have your acromioclavicular joint, which is right over here. This is your clavicle. This is the acromion. Okay, this is called the acromioclavicular joint. As you can see, طبعا the acromioclavicular joint, you don't want it to separate. You don't want it to go anywhere. It's stable. So the acromion and the clavicle, they just glide along each other. And you also have your intercarpal joints, your intertarsal joints, and your subtalar joint. Now, your intercarpal joints and intertarsal are basically the joints that are in your foot and in your hand. Okay, I talked about the carpals that are over here. There are joints that are between them. Like here are the carpals, by the way. This is the carpals. There are joints between them, as you can see. It's also pivot. Also plane, not pivot. It's plane. Okay, and it just allows gliding. It does not allow like actual movements in any direction. And you have your subtalar joint. Now, this is just for visualization. Your subtalar joint, this is like, let's say this is like the foot. Your foot is comprised of like a bunch of bones, but I'm just drawing like the important ones. So here's like a bone, and here's another bone. This bone, I think, is called talus or something like that. I forgot بصراحة. But this joint over here, this one that's right over there, that's called your subtalar joint. You don't have to like memorize exactly where it is, but this is just to visualize because I want you guys to understand before you actually memorize. So yeah. And hinge is the easiest in my opinion. Uniaxial, okay? Just one direction, flexion, extension. Your elbow joint, your ankle joint, and your knee. Now, in our, I think it was an MCQ or OSPE, I'm not sure. They gave us a knee, a picture of a knee joint, and they were like, what type of joint this is? And there were two options. There was hinge joint and there was modified hinge joints. If you get an MCQ and it tells you pick one of those, you pick modified hinge joint because that was the correct answer apparently. And if that comes in your OSPE, you write modified hinge joint for the knee joint. The rest just write hinge. And this is just a summary of everything that we just talked about joints. And please take care of the difference between functional and structural. Functional means this. طيب. When they ask about functional, you write synarthrosis, amphi, or die. When they talk about structural, you talk about fibrous, cartilaginous, and synovial. And we're done with joints, guys. Any questions? Let me go through the questions. Okay. If they ask about the type of joint according to movement, should we say multi-axial, biaxial, etc., or something? Okay. According to movement, movement is a function, so I believe that you should say synarthrosis, amphiarthrosis, وأشياء كده. If they ask about the range of movement, I think, or like the directional movement, I think that's where you say multi-axial, biaxial كده. But I think it's best to double check with Dr. Atif or someone. Okay. Okay, I'll go back to the last slide. The last slide is just a summary. It's everything that we talked about in just one page, in case you guys are like rushing through and you want like a quick review. No problem. Structure, cascade, synovial joint. Do we say synovial, pivot, synovial hinge? Structural. Okay. When they say what's a structural classification, you say synovial. When they say, okay, like what type of joint is it? طيب. This is where you say, okay, ball and socket, hinge, whatever. Just to be safe, I do like advise you to write both just in case. And just to be safe, like it doesn't hurt. How to answer these properly. بصراحة guys, okay, to answer them properly, as I said, it's just you have to take care of the wording. If they say functional, طيب, you think about synarthrosis, diarthrosis, and amphiarthrosis. If they say structural, you think about these. Based on yes, based on articulating surface, we say hinge joint and bone socket or whatever. Okay, is everything else clear, inshallah? I hope everything is clear. Okay, let's move on to bones. طيب, bones is our last part of our musculoskeletal system. Okay, so bones is very easy, alhamdulillah. You have your axial skeleton, number one. Your axial skeleton, as I like to think about it, axial means axis. So it's axis, every time I think about axis, that means something that's in the middle. Okay, so axial skeleton usually includes that most of the things that are in the middle. So you have your skull, your ossicles, which are your inner ear, and your hyoid bone. Okay, and you have your rib cage, and you have your vertebral column. طيب, this is what composes your axial skeleton. Everything else is your appendicular skeleton. Everything that is peripheral, that is appendicular. Your clavicle, okay, your clavicle, your scapula, your arms, pelvic girdle, lower limbs, everything else is appendicular. Now, bones, we have 6 types. Sesamoid, pneumatic, and irregular. So we're going to dive deep into each and every one of them. Now, long bones, from the name, they're longer than they are wide. Okay, you have a regular long bone, and you have a miniature long bone, and you have a modified long bone. First, let's talk about regular. Regular is just like a normal long bone, like your femur. This is your femur bone, by the way. Okay, your regular bone, as we said, is longer than they're wide. And you also have your humerus, which is the bone that's right over here in your arm, your radius and ulna that we talked about a lot, and you have your tibia and your fibula, which is down there in your leg. Okay. Then you have your miniature long bone. Now, why do we call it miniature? Because it's genuinely miniature. Okay. When I see this, like Anna last year when I saw this, I was like, this looks short. But no, guys, always go back to the definition. They're longer than they are wide. So since your metacarpals, here are your metacarpals, they're longer than they are wide, this is classified as a long bone. But since they're actually tiny compared to this, okay, we classify it even further by saying miniature long bones. So guys, if they get this in your exam, don't say long bone only, you say miniature long bone. And that also includes your metatarsals and your phalanges. This is your phalanges, by the way, your like fingers. Okay. And lastly, you have modified long bone. Clavicle, okay. It's like an S-shaped, it's curvy. It's not straight like this, and it's not straight like that. It's like curvy, right? And your clavicle, as we said, go back to the definition. They're longer than they are wide. So your clavicle is a modified long bone. Okay. Short bones are basically cube-shaped with equal dimensions on all sides. What do I mean? I mean like your carpals. Your carpals, okay, they're very short, بصراحة. Like, they're cube-shaped, okay, and they're kind of equal on your vertical and your horizontal dimensions. They're kind of equal. And you also have your tarsals. This is more clear as like cube-shaped. This is cube-shaped, and it's kind of equal horizontally and vertically. So your carpals and your tarsals. What about flat bones? Flat bones, from the name, they're thin, they're flattened, and they're usually curved. By curved, I don't mean, like by curved, like sometimes they're slightly curved or they're actually curved, like your scapula. Your scapula, ignore this part, okay? But if you take the majority of the scapula, it's a flat bone. It's very flat, it's very thin, okay? You also have your sternum. Your sternum is in the middle of your chest, okay? It protects your heart. Your sternum is kind of curved like this, okay? And it's a flat bone. And you have your ribs. This is what I meant by it could be fully curved, like your ribs. Your ribs are also classified as a flat bone because they're thin and they're flattened. Okay, sesamoid bones. Sesamoid bones, there's only one type, okay? And they basically develop between the tendons because they want to reduce friction between the bones, okay? And what is something that we use all the time, alhamdulillah, يعني ربي أنعمنا فيه, okay? It's walking. Walking, guys, we walk all the time, صح? And that means like our knees will, if we did not have our patella, okay, our knees are susceptible to injury. So patella is like the only sesamoid bone, okay, that they gave as an example, okay, and it's basically your kneecap. Pneumatic bones. So pneumatic bones, from the name, pneumatic means like respiratory, okay? Like when I think of pneumatic, I think of breathing and like air. So pneumatic bones are hollow bones that contain air-filled spaces, okay? Like your ethmoid. Your ethmoid bone, it's like above your nose or somewhere like behind your nose, okay? And it's basically filled with air-filled spaces. As long as you see so many spaces like this is pneumatic 100%. And you have your maxilla. Your maxilla is right over here as well. And this is a space, طيب, and it's filled with air. So that's a pneumatic bone. Irregular bone. Now, irregular bone, why do we call it irregular? Because they generally don't fit in any of the categories that I just talked about. So they're like the sacrum and the coccyx, okay? They don't fit into any of them. It doesn't look flat, doesn't look, I don't know, long. You have your mandible, which is your jawbone, and you have your hip bone, okay? And lastly, you have your vertebra. And vertebra, let's talk more about vertebra, okay? Now, before I want to talk about vertebra, I want to see if you guys have any more questions. Is everything clear so far? Alhamdulillah. No, the hip isn't flat because listen, when we talked about the scapula, it's literally just a tiny part that doesn't look flat. But when you talk about the hip bone, your hip is like curved like this awalan, and then you have a socket over here, you have a foramen over here, and it's like long from here, it's just irregular. So we can't classify it as a flat bone. Your sacrum, they're fused vertebrates. So sometimes you can classify it يعني outside of vertebra. I mean, your doctor in his lab slides, he classified it as like something different. Pelvis, not a flat bone. Pelvis, no, it's not a flat bone. It's a irregular bone. Okay. Okay, let's move on to vertebra. Now, vertebra, we have 33 vertebrae in the body. And I think I saw someone say in 26 or something, if you count in the fused. But without fusing, 33 vertebrae in the body. You have 7 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 4 coccygeal. Okay? And this is how it looks like. We have cervical, thoracic, and lumbar. Now, cervical, it's the smallest out of the 3. Okay? Like good tip to think about, and your spine, okay, it starts off really small and then it goes wide. Okay, so this is like from smallest to largest, inshallah. Okay, it's also oval shaped. What am I talking about that's oval shaped? I'm talking about the vertebral body over here. The body here is oval shaped and it has a large and triangular foramen. This is a foramen. Okay, it has a large and triangular foramen. Compared to these are small, but this one is large, and it kind of looks like an elephant. So if you see like a vertebra that looks like an elephant, okay, that's cervical. What about thoracic? Thoracic, medium-sized, between the two, okay, and it's heart-shaped. The foramen here is heart-shaped, okay, and it has a small and the body here. The body here is heart-shaped, and the small and circular foramen. I know it kind of looks triangular, but your doctor says it's circular, so you go with that, okay? So it's a small and circular foramen. And it looks like a giraffe. And this one honestly looks like a lot like a giraffe. So any like vertebra that you see looks like a giraffe, that's your, thoracic. Okay, lumbar. Lumbar is the largest out of the 3. It has a kidney-shaped body, and it has a small and triangular foramen. This is why he differentiated between the two. The small and circular is thoracic, small and triangular is lumbar, small and triangular. And it has like a kidney-shaped body over here. But now, there's like a key rule to like when we talk about the nerve, like when we classify, okay, is this C8, C1, C2, whatever. So for the cervical vertebra, guys, this is very important, please. They get this every single year, so please stay with me here. For the cervical, this is your cervical vertebra. You have C1, C2, C3, C4, C5, C6, C7. Only 7, okay? Keep this in mind. You have only 7 cervical vertebrae. As you notice, you have a nerve that is above the C1. So we call this C1 nerve, okay? And then we go down. We have the nerve that is above C2. So we call this C2 nerve. And it continues, the pattern continues. So the nerve that is above the vertebra is the name of the vertebra. So if this is like C4, this would be C4 nerve. However, let's go here. This is C7, okay? C7, above it is a nerve. And we said the rule for cervical, above is the name. So this is C7. But what about the one that is below it? Okay? The one that is below it, guys, is not T1. It's not T1, it's C8. Okay? The one that is below C7 is C8. And this is why like classifying like the names of the nerves here is different than thoracic and lumbar because of C8. So here, okay, here's where we're going. So this is C8, right? Now we have T1. T1, the nerve that is below T1, okay, is called T1 nerve. Below T2 is called T2 nerve, and so on. And it continues to lumbar as well. Lumbar, L4, the one that is below it is L4 nerve, and so on, okay? So the way that you can like know this is cervical comes above, the rest go below, okay? Except C8. C8 is below. I hope you guys understood that. Did you guys understand? Which previous slide? This one? Do you want me to re-explain? Okay. just to go over this quick. No, okay, you just want to see it. Do you guys get this one? This is really important. Do you guys get this slide? Alhamdulillah. Okay, great. Let's go on. So now that we had like a bit of overview of vertebrae and whatever, what is found inside the vertebra? Your spinal cord. What is your spinal cord a part of? Your nervous system. So let's talk about the nervous system. So we talked about a bit of about the vertebra. Now, before we get into the actual spinal nerves and whatever, let's talk about this image, okay? This is like you're looking at your vertebra from a superior view, okay? So I'm looking at it from above. It's like I had a cross section and I looked at it from above. So this is your vertebral body, okay? And this is your spinal cord. Their spinal cord runs directly like anterior towards your vertebral body, and it runs through the neural canal. So where is the spinal cord found? In the neural canal, okay? And as you can see, you see nerves coming out of the spinal cord. The nerves that are coming out of the spinal cord, okay, they come out of the intervertebral foramen. Intervertebral means it's between the vertebrae, okay, between the vertebrae. Foramen means an opening. So intervertebral foramen is where the spinal nerve comes out from, okay? Now, let's get into the actual spinal nerves. Now, you have 31 pairs of spinal nerves, okay? And the way that we like to memorize it is same Dave, okay? Sensory afferent, motor efferent. So sensory nerves are afferent, okay? The signal comes, someone hits you, you get the signal towards your CNS. Motor efferent, your CNS is like, okay, I want to hit back. So I'll send the signal towards my peripheral and I'll hit back. So sensory afferent, motor efferent. Dave, dorsal afferent, ventral efferent. Dorsal afferent, ventral efferent. Dorsal, that means if we connect them together, dorsal is sensory, ventral is motor. Okay, guys? I hope this made sense. Now here is our vertebra, okay? And this is like the central canal that we were talking about, the neural canal in the middle. And this is the posterior median sulcus. So how do you guys, sometimes they'll give you like a vertebra, okay? And they can flip it. They can flip the sides. Maybe like the top is anterior, the below is posterior, or they could flip the opposite. So how do we know where is anterior and where is posterior? By this. Posterior median sulcus is a very small groove in the vertebra, a very small groove, okay? And your anterior median fissure, okay, is a deep groove. It's a deep groove. So when you compare the both, like this one is way deeper than the other one. So wherever it's like deeper, that's anterior side 100%. Then now let's talk about this, okay? Here is basically where all the connections happen. And what do we call this? We call this the dorsal horn, dorsal horn, okay? And we call the one like in the middle, lateral horn, and then the one that's anteriorly, ventral horn. So dorsal horn, dorsal, by the way, means back. So posterior median sulcus, posterior side, dorsal horn. Lateral horn, middle, and ventral horn, okay? Ventral means anterior, front, okay? So ventral horn, anterior median fissure, okay? And like we said, dorsal is sensory, ventral is motor, okay, guys? Now let's introduce some nerves. Now we have two nerves coming out of the dorsal horn side, okay? So what do we call this part? Okay, this part that is going inside the vertebra, okay, like this bundle of nerves are going inside the vertebra, the dorsal rootlet. You guys know like the words like inlet and outlet, okay? Now, because this is afferent, it's gonna be an inlet. So it's gonna be a dorsal rootlet that's going in. It's a group of spinal nerves that goes in. And here is your dorsal root, which only contains sensory nerves. Your dorsal root only contains sensory nerves, okay? Then you have your dorsal root ganglion. Ganglion, okay, basically it's a swelling in the root, and this is where you find your cell bodies of your sensory nerves. Like it? I hope that made sense. Now we have our nerves that come out of the ventral horn. Now, as we said in هنا في dorsal rootlet, there's of course is going to be ventral rootlet, but it's not an inlet, it's an outlet. So it's where the nerves are coming out, because we said that ventral means efferent, okay? And this is your ventral root. It only contains motor nerves. طيب? Very important, guys. They can put like a pin over here and be like, يعني, what type of nerves are there? You have to say motor nerves, okay? And you'll see why. Because now we have our rami, okay? Our rami. You have dorsal rami and you have your ventral rami. Now, basically, and it means now you have a mix. You have a mix of nerves. You have sensory with the motor, and you have this sensory with the motor. The only difference is one is dorsally, one is on the posterior side, and one is on the ventral side. Now, how do I know? Okay, how do I know which one is which? Which one is dorsal? Which one is ventral? Since they're practically the same, depending on the dorsal root ganglion. Guys, when you see the root ganglion, okay, خلاص, you know you're in the posterior side. طيب, you know this is dorsal. This is dorsal ramus, or depending on the posterior median sulcus. Okay, this is a summary of everything I just spoken right now. Like everything I just said is right over here. And yeah, now we have common conditions that we see. بصراحة guys, يعني I've never seen this in a question before, but it was in your slides. So I wanted to add it just in case I get it for you. So you have something called a slip disc. A slip disc is kind of like a herniation, okay? And this usually happens in C7 and C6 and C7. This picture, by the way, is not included. I got this from Google just to explain on it. This is not included, but this picture is included, okay? But I just got it so I can explain what's a slip disc. So basically, as you can see here, you can have like a vertebra split out and it will protrude onto the spinal nerve. And this usually happens to C6 and C7, between C6 and C7. Guys, I want to ask you guys right now to answer in the chat for me. طيب, what nerve is between C6 and C7? C7. Yes, you're correct. Exactly. So a slip disc would always impinge on a nerve C7. Okay? Okay. Then you have Lou Gehrig's disease. Lou Gehrig's disease, honestly, very simple. You just have to memorize this name. طيب. It's a fatal disease. And you see over here, here are your ventral rootlets. Okay? In your ventral rootlets, you have your anterior horn. Remember this, your ventral horn. طيب. But we can also call it as an anterior horn. You have your anterior horn cells. When you have a degeneration in these cells, okay, like they're not actually getting generated anymore, you have Lou Gehrig's disease. That's all you need to know. And yeah, okay, before I test you guys, do you guys have any questions? Count vertebra in the image. Yes, of course. But C6, okay, this is obviously like cervical because here you see the skull. طيب, and you can see like small to big. طيب, this is skull. So you see, start from C1. Always start from C1. Okay, you see vertebra number C1. Okay, the spinal nerve that's right above it is C1 nerve, and that's how you can count the vertebra itself. So the vertebra is under the nerve and cervical. In thoracic and lumbar, it's the opposite. The vertebra is below the vertebra is معلش, the nerve is below the vertebra. And also for C8. Repeat the disease scanned image. This one? No, I told you guys to ignore this image. This image, I just put it in here so I can explain for you guys what's a slip disc. Like, how does it look like? How does it protrude on the spinal nerve? They won't get you this. Don't worry. This isn't included. This is included. Oh, it was in Vlad's lecture. Oh, معلش, I didn't get it from Vlad. They will not get this in OSPE. I don't believe in you guys had radiology in labs. Correct me if I'm wrong, but they would not get a picture from your lectures that was not discussed in your OSPE. Is that okay? Yeah, the one between C7 and C8 is دقيقة أصلا ما في C8. Okay, the one between C7 and T1 is C8, but I was talking about C6 and C7. The one between them is C7. Okay, and for the okay خلاص. Disease. Okay, you just have to know إنه slip disc will protrude on C7 because slip disc usually happens between C6 and C7. Luger-Higgs disease is just a degeneration in anterior horn cells, the cells that are over here. Okay, like they could ask you, for example, I'll give you like a question طيب from my head. They can put a pin here on the ventral horn and they could tell you what is this, and you'd say ventral horn. What disease can come from this? Luger-Higgs disease. If you didn't take the disease in lab, it was in your slides. So that's why I'm telling you guys, this never came up for us, but it's in your slides, so I don't want to miss anything for you guys. Okay, so I hope this is all clear. Inshallah, we can move on and we can test you guys. So first, I'd like to tell you that I'd like you guys to tell me what is A. Okay, I see a lot of ventral horn, and that is correct. It's ventral horn. It's not dorsal horn. Guys, look, you see this little groove? It's actually just a tiny groove here. This is your posterior median sulcus. But look at this big groove over here. That is your anterior median fissure. And one thing that you can see is from this thing. What is F? Yes, dorsal root ganglion. Yes, dorsal root ganglion. Also, guys, when you type in the OSPE, when you like type it like your answer in the OSPE, please use like the full name because there's many ganglions in the body. طيب? Okay, from the DRG, okay, this is dorsal posterior. So this is your, what is B? Dorsal horn. Yes, you're correct, guys. And what is E? Dorsal root. Yes, it's not the rootlet, guys. If the rootlet was over, if the pin was over here, this is the rootlet. It's like where once it enters the vertebra, but right in the middle is the root. Okay, what is D? D should be easy as well. It's in the middle. Yeah, ventral root. And what is C? Lateral horn. Okay, G is also like the rami, but since you can only see here one, you can say spinal nerve. If they put a pin on G, just say spinal nerve. Yes, صح, you're correct. Spinal nerve. And here are all the answers. Okay, guys, now we're on to our last system, which is, what is F? F is dorsal root ganglion. E is dorsal root. Dorsal root. You have your answers over here, inshallah. Okay, now we're on to our last system. Grooves anterior median fissure, posterior median sulcus. Okay, now let's move on, guys. Now we're on to our last system, which is our vascular system, our arteries and our veins. So we're splitting this into thoracic cavity and our abdominal cavity. In our thoracic cavity, let's start with our heart. Okay, pretend this is a human heart. I know it doesn't look like one, but inshallah, we can go about this, okay? So here is your aorta. And your aorta, we can split it into 3 parts, okay? The first part that is ascending, that is going up, we call this ascending aorta. The second part, which is arching, this is the arch, we call this the arch of aorta. The last part, which is going down means descending. So this is the descending aorta. Make sense? Inshallah, makes sense. Now we have our aorta and it's gonna branch out, okay? And the arch of aorta will branch out into 3 arteries. The first one will be our left subclavian artery, okay? Our left subclavian artery. And keep in mind, it branches out على طول من الarch of aorta. Then you have your left common carotid, okay? Your left common carotid. And then lastly, you have your brachiocephalic trunk. You only have one brachiocephalic trunk artery. Like in the arterial supply, you only have one. Keep this in mind because it's important later. طيب. And your brachiocephalic trunk will branch out into your right common carotid and your right subclavian. What's so nice, guys, whenever you see right, always expect a left. So هنا في left subclavian, you're always going to find a right subclavian. هنا في left common carotid, you're always going to find a right common carotid, okay? So left common carotid and left subclavian, they come out of the arch of aorta. Brachiocephalic trunk comes out from arch of aorta, then it branches out into right common carotid, then it continues to be a right subclavian artery, okay? This is for thoracic cavity. What about the abdominal cavity? Now, imagine this descending aorta, it's going down and it's going down into your abdomen. When it goes down here, it splits into two. And since it's in your abdomen, we call this your abdominal aorta. طيب? And it splits into two. It splits into your right common iliac artery and it splits into your left common iliac artery. طيب? Common iliac artery, طيب, right and left. Then your right common iliac artery and your left, they will branch into two arteries. It will continue as one over here, but it will branch into like one over internally and one internal. طيب? So the one that's internal, we call it your right internal iliac artery and your left internal iliac artery. Same thing. Right external iliac artery, left external iliac artery. And then they both continue to become the right femoral artery when they reach the leg. طيب? Cool tip. When you see common, always expect internal, external. Always. طيب? They didn't cover it in the common carotid, but that will also go into external, internal. So yeah, as I hope arteries is all clear. Okay, now let's talk about veins. We're back to our heart. Okay. Now veins, venous drainage. طيب. Arteries, they branch out, then they circulate. صح? Venous veins, they join together to create one vein. So instead of going out from the heart, now we're going in and eventually ending up in the heart. What do I mean? Like this. We have these two veins. These two veins are called, we're in the neck region, by the way. This is in the neck. طيب. These two veins are called your left internal jugular vein and your left external jugular vein. طيب. Your left internal and your your left internal and left external jugular vein. طيب. Those two connect together, they join together to become the jugular vein. Okay, see how simple? External, internal join together to become jugular vein. Now, jugular vein, the left jugular vein will join together with your left subclavian vein. طيب, subclavian. Remember subclavian artery? Now there's a vein. Your left subclavian vein, and they will together make the left brachiocephalic vein. Okay, left jugular vein joins with the left subclavian to make the left brachiocephalic vein. And the same thing, same exact thing happens to the right side. Same exact thing. The only difference, as you can see, the brachiocephalic vein in the right side is smaller than the left brachiocephalic vein. Like it's shorter than the left brachiocephalic vein. Why? Because those two will eventually join together to become the superior vena cava. طيب. Superior vena cava is located in the right side of your heart. طيب, in the right side, more towards the right. So when you're trying to like drain all the blood in, طيب, you're trying to reach all parts of your body. Since it's in the right side, it will have easier access to the right side, right? But the vein has to extend all the way to the left to reach the left side of your body. Okay? So your right brachiocephalic vein is always shorter than the left brachiocephalic vein. طيب. You don't have to know the reasoning, but you have to know and it's shorter because they can point a pin on it and you have to mention right or left. And your SVC continues down to become the IVC, طيب, which is your inferior vena cava. Okay, now your IVC, your inferior vena cava, it continues down, طيب. It goes down and down and continues towards your abdominal cavity, and still, this time we still call it an IVC. Okay? Oh, معلش. Okay, there still continues to be the IVC. طيب. معلش, guys. 1 second. Okay, as I said, in venous drainage, we join together So we're gonna start from the bottom now. طيب. Your right external iliac vein, okay, and your left external iliac vein will join together with what? I want you guys to answer this one. Like, think about arteries. Think about arteries. What was inside here? Internal, صح. Internal iliac, right. So they will join together, okay? The internal and external, they will join together to become the, now you can say it, the common iliac. Exactly. They'll join together to become the common iliac. Okay, just like this. And the left common and the right common iliac vein will join together to become the IVC. And that's it. That's venous drainage for you. Okay, so I'll just explain on the model, because this is the model, inshallah, that they'll probably get for you guys if they ask you about arterial supply and venous drainage. Okay, here's your ascending aorta, and here's the arch. It arches and then it goes down to descending aorta. You can't see the descending aorta like down there because it's right behind the heart. Okay, your arch of aorta branches out into three arteries. Okay, it branches out into your brachiocephalic trunk and your left common carotid and your left subclavian. طيب. Your brachiocephalic trunk will branch into right common carotid and the right subclavian. And then if we go down, here is your abdominal aorta. Your abdominal aorta will go into the left, your left and right common iliac, and your common iliac will go into the internal iliacs and the external iliacs. And when it reaches down there, when it reaches like right next to the femur from the name, it becomes the femoral artery. طيب. What about venous drainage? For venous drainage, you have your external and your internal. Okay, easy way to know which one is external, which one is internal. The one that is going towards the brain, you can see this one is going towards the brain, like inside, that is your internal. The one that just goes outside, this is your external. Okay, guys? Don't mix this up, please. So the one that's going towards your brain is internal. The one that goes outside is your external. And those two join to become the jugular vein. The left jugular vein joins with the left subclavian vein to become the left brachiocephalic vein. طيب. And then same thing that happens here. Right jugular with the right subclavian to become the right brachiocephalic vein. So you see how small it is compared to the left one? So yeah. And then they both join together to become the SVC, superior vena cava. And then you go down, here's your IVC, your inferior vena cava. Okay. And same exact thing. Internal iliac joins with external iliac to become common iliac. And then common iliacs on both sides will join together to become the IVC. Okay, guys? So before I ask you guys, is everything clear? Why isn't there a right brachiocephalic trunk? There is. Oh, wait, artery, you mean? معلش. For artery, honestly, I would guess in it because there's an arch and the aorta is kind of in the middle. So I think it can just like cover both sides. I don't know. This is how God made us. Veins, can we use a brachiocephalic trunk to name the left and right brachiocephalic parts? What do you mean? No, you have to call it vein. Trunk is this one artery. Trunk is this one artery. You have to call it a vein, okay? Left internal and external jugular merge together. But doesn't external drain the subclavian? Where is the internal joins with the subclavian? Doesn't external drain the subclavian? No, I don't think so. I'm not sure what do you mean, but it's like it's external, which is right over here, and the internal, they join together to become the jugular vein first. Then the jugular vein will join with the subclavian vein. brachiocephalic artery, that one I'm not sure بصراحة. But guys, I'd really urge you to be specific in OSPEs. They really take like the wording to account. يعني they don't play around with that. Okay. What forms the SVC? We can say right and left brachiocephalic trunks. No, right and left brachiocephalic veins. When you're talking about trunks, that is artery. Please use like the exact wording. Okay. Don't mess around with the wording because OSPE is very specific, guys. Okay. Inshallah, that makes sense. Okay. So, نحن الحمد لله, we finished all the body systems. Okay. Now question time. So, name the type of muscle according to, no, wait. Guys, you've made the mistake. أيوة, parallel. بالضبط. parallel. Pay attention to the question. According to the line of pull, that's parallel. Name the muscle shown. Now you can say it. Sternocleidomastoid. Exactly. Sternocleidomastoid. Okay? So take care of the wordings, please. And that's it, guys. Now we can go into histology.
Okay, so now for general histology, not everyone's favorite, but inshallah it will be easy. First, we have types of epithelium. Okay, now epithelium from the word epi means outermost, epithelium means layer. So the outermost layer, طيب. Now epithelium lines almost every hollow organ, such as the heart, the stomach, your esophagus, everything in your body that is hollow is lined by epithelium. And it also lines ducts, everything, okay? And arteries, veins, also your skin is lined by epithelium, okay? So the first type of epithelium is called simple squamous. Okay, now I know this is not a good picture, but this was the picture that they used in the slides. Okay, now simple squamous epithelial cells are flattened. Okay, so simple means one layer. Okay, it's just one layer. Squamous means flat. Okay, so these are flattened, but we're looking at them from the top. Like this is a top view of them. That's why they don't look flat to us. Okay, and they are polygonal in shape, so that means they kind of look like they have sides. Okay. And they are so thin that you can only see their, like you can only identify them from their nuclei. Okay, and we'll see this in another picture. So here is the picture of an artery. Okay, so this is what an artery looks like. So it's hollow from the inside. So it's supposed to be lined by what? An epithelium. And the type of epithelium is called simple squamous. Okay, so can you guys see here? It's so flat that you can only see the nucleus. Okay. And it lines the arteries to reduce friction for the blood to flow, okay? And it's also found in alveoli, which are the structures that are used for gas exchange when you breathe, okay? So why are they lining the alveoli? Because they're so thin. So gas exchange can be more efficient, okay? So this is all for simple squamous. So they'll ask you to identify the type of epithelium, and then they might ask you where it's found, okay? So you can tell them lining of arteries, okay? Then we have simple cuboidal. This is the only example of simple cuboidal cells that were given in your slides. Simple cuboidal. So can you guys see the cells? Look, it looks like a cube, okay? So cuboidal. And the nucleus is quite round and big. So the first one, simple squamous, was flat, okay? And the nucleus also was flattened. Here, the nucleus is round and it's quite large, okay? And the cells are cube-shaped. Now, these are used whenever we need absorption, secretion, or excretion, okay? So the cuboidal cells are also an intermediate between squamous cells and columnar cells. We'll see columnar cells later, but columnar cells are quite tall, okay? So cuboid is just between the columnar and squamous, the flattened ones. Now, this is a picture of the thyroid gland, okay? And these are thyroid follicles. So each follicle is lined by what? simple cuboidal cells. Okay, why? Because in the thyroid gland, we secrete hormones. Okay, so what type of epithelium is used for secretion? We said simple cuboidal. So it's lined by simple cuboidal cells. Okay, simple means one layer, cuboidal, cube shape. Next up, we have simple columnar. Okay, now this one actually came in our exam, and simple columnar cells are used for absorption. Okay, now for absorption, for us to absorb as much as possible and to make it a lot more efficient, we need to have the maximum amount of surface area. Okay, so for that, we have structures called microvilli, which I'm going to show you guys in the next slide. But first, to identify simple columnar, the cells are quite tall, actually. Like, can you guys see? This is one cell. Can you guys see how tall it is? Also, the nucleus is elongated. Okay, and it's not round. So cuboidal was round. In squamous, it was flattened. In columnar, it's quite elongated. Okay, and we find them in the small intestine, where we absorb the nutrients from food we eat. Okay, so it's used for absorption, tall, and elongated nuclei. And also the nuclei are towards what? The base. Okay, so here is the lumen. Can you guys see where it says L? This is the lumen. So this is the tube. This is the top part of the cell, and this is the bottom. The bottom part of the cell is called basal, the basal side. Okay, so the nuclei are basal nuclei. They're towards the bottom part of the cell, and they're elongated. Okay. Now, the microvilli, when you zoom in, okay, this is what it looks like. Can you guys see these structures? These are like projections that are called microvilli. Now, in the slides, they said they're made up of actin filaments, so that might be important. They might ask you, for example, to identify this, and they might ask you in the follow-up question, what is it made out of? And you can say actin filaments. Now, these increase the surface area for absorption. Okay. Now, in between the simple columnar cells, can you guys see these like circles, these empty circles? These are called goblet cells. Now these secrete mucus. Okay, goblet cells secrete mucus for what? To make it more, to lubricate the lumen. Okay. Also, we can find simple columnar epithelium in the oviduct. That's all you have to know from this slide. Like, can you guys see how tall it is? How tall the cells are here? Okay, so this is the oviduct. This is what the oviduct looks like. Okay, there were no details mentioned. And that is it for the simple epithelium. Do you guys have any questions? Okay, how can you differentiate between cilia and microvilli in histo? Okay, let me go back to the slide. If it's quite zoomed in, how can you guys see how like straight the microvilli are? Like they're quite straight. However, cilia would be like hair-like. They look like hair. These look like brush bristles. Okay. Also, in this slide specifically, you can't really see the microvilli. You just have to know it. Okay, like we can't really see it. However, cilia is quite visible, and I'll show you a slide with cilia on it. Okay. What is oviduct? Oviduct is the fallopian tube. It was just mentioned in the lab slides. That's why I put it here. It's not really important. Yes. Also, someone said cilia is way longer than microvilli. Yes, that is true. Yes, if they ask you about properties of simple columnar cells, tell them microvilli. It is counted. You can also say that they have basal nuclei. They're tall cells. No, the slide with cilia is not the oviduct slide. It's it also. No, oh yes. This one, this slide. Wait, let me show you. Yeah, this one. Okay, but the cilia aren't really clear here. Okay, I'll show you another clearer picture. Okay. Any more questions? Okay. Okay, now for the stratified squamous. Okay, as we said, squamous means what? Flat. Okay, stratified means more than one layer. Okay, simple squamous was one layer of flat cells. This is multiple layers. Can you see how many layers we have here? Now this is your esophagus. Can you guys see? It's a tube. Okay, and in the esophagus we can find stratified squamous epithelium. Okay, it's mainly for protection. Okay, because food passes through your esophagus, so to protect it from friction, we have stratified squamous. Okay, now if you look here, can you guys see the flattened cells? These are your squamous cells, and we have more than one layer, so stratified squamous. However, at the base, we have columnar cells. Can you guys see the basal nuclei? Okay, we can't really see if they're tall cells or cuboidal, but just know that they are columnar. It was mentioned like that in the slides. Okay, so the cells at the base are columnar cells from the nuclei. However, when you see these flattened nuclei, these are stratified squamous epithelium. Okay, if they just give you this slide and they ask you what type of epithelium, just tell them stratified squamous epithelium. Don't mention the columnar part. Okay. Next, we have pseudostratified columnar epithelium. Now, this lines your trachea. Okay. And pseudo means false or fake. Stratified means more than one layer. So fake more than one layer means we only have one layer, but it looks like it's more than one layer. So it looks like it's stratified, but it's actually simple. It's just one layer. Okay. Now, staggered nuclei means like it's kind of up, down, up, down, up, down. Okay. Like a zigzag shape. Okay. And we said that it looks like it's stratified, but it's only one layer. Now, can you guys see here the nuclei are also towards what? Towards the basal side. Okay. And on the basal side, we have this basement membrane, which is here. Now, the basement membrane is what attaches the cells to the trachea itself. Okay. Now, as I said, whenever you see these round clear cells, these are goblet cells. Okay. They secrete mucus. Okay. They are between what? They are between the pseudostratified columnar epithelium. Okay. Now, first, someone asked me about cilia. Can you guys see here? The cilia are a lot more clear. Okay. They look like hair. Also, this is quite low yield, but they might ask you about it. Can you guys see here on the cilia? We have nuclei here on top of it. These are called basal bodies. Okay, we don't need to know their function or anything. They're just there. Okay. Then we have transitional epithelium. Now, as soon as you guys see this, just immediately think urothelium or urinary tract. Okay. Now, what lines the urinary tract is transitional epithelium. Transitional epithelium is also called urothelium. Now, can you guys see the shape here? It's kind of, I don't know if you guys can tell or not, but it's umbrella shaped, like here. Okay, it looks like an umbrella. Also here. Now, that allows it to what? Stretch. So its function is to withstand distension or stretch. That's why your bladder can stretch and fill with urine. Okay. So it's called transitional because it changes its appearance. Okay. Now, before we start connective tissue, any questions? We're done with the epithelium. Yes, the pseudostratified columnar epithelium is found in your respiratory system, specifically the trachea. No, not all columnar epithelium have microvilli. It's only the ones in your small intestine, because that is the example that they use in the exam. They're going to give you a slide from the small intestine, and they'll ask you which type of epithelium this is, and you tell them simple columnar epithelium with microvilli if they ask for like a feature. For the examples mentioned, yeah. So you have to memorize the locations that they gave you because they mentioned them in the slides. So they might test you on it. This is the question regarding would they ask us where the epithelium is? Okay, I think that's it. Should we move on? Okay. Now for connective tissue, now the first layer we had was epithelium. Okay. Now under the epithelium, we're going to have what? The connective tissue. The first type of connective tissue is called loose areolar connective tissue. Now it's made up of cells, and specifically the cells are called fibroblasts. Now these fibroblasts release collagen. Okay, they secrete collagen. Now collagen is all this like pink fibers you can see here. All these pink fibers are what? Collagen fibers. Secreted by what? The fibroblasts. Okay, and ground substance. Ground substance is kind of like gel material. You don't really have to know it. For the OSPE, you might need to know it for the MCQs, but for the OSPE, they don't usually ask about ground substance. They ask about fibroblasts and the fibers, which are collagen fibers, secreted by the fibroblasts. Okay. Now, loose areolar connective tissue is found in blood vessels. Okay. This dark part here is called dense connective tissue. So loose connective tissue, from the appearance, it looks light. Okay, so loose connective tissue. However, dense connective tissue is a lot more denser and it looks darker. It's a lot more pinkish. Okay. We also have here two types of fibers called elastic fibers and reticular fibers, but we can't really see them. So if they ask you, they point towards a pink area like this and they ask you what type of fibers are found here, just tell them collagen fibers. Okay. Now for dense irregular, okay, so that was loose irregular connective tissue. This is dense irregular connective tissue. Now here it's a lot more pink, it's darker. Okay, why? Because from the name it's dense. Okay, so it has to be darker than the loose areolar. And why is it darker and why is it more dense? Because the fibroblasts here secrete more collagen fibers. So if you have more collagen fibers, the pinker it gets. Okay, they'll only ask you to identify this. These are the fibroblasts, and this is the collagen fibers. Can you see them? These pink fibers here. That is it for dense irregular. Then we have adipose, which is basically fat. Okay, so can you guys see these? It's quite faint, but can you guys see these outlines of cells? Now these are called adipocytes. So adipose is the tissue. Adipocytes are the cells that make up this adipose tissue. Okay, so adipose is used for insulation, and cushioning the skin and other organs, of course, for protection. Can you guys see how thin the walls are? Now, why is that? Because adipocytes are basically fat cells. However, when we prepare the slide, okay, when we process the tissue itself, all the fat gets washed off. That's why it appears like empty or white to us. Okay, so whenever you see white cells with a thin cytoplasm or like thin outer part, okay, that is called what? Adipocytes of adipose tissue. And can you guys see here the nucleus, how small it is? It's usually in between the cells, like 1, 2, 3, and then we have a nucleus here in the middle. Okay. And that's it for adipose. Next, we have dense irregular. So we did dense irregular. Now we have dense regular. Okay. So dense regular looks even more darker than the dense irregular. So again, collagen fibers, but they are more densely packed. And here they are parallel. Okay. And this is found in tendons of muscles. Okay. So can you guys see here the muscle? Then we have the tendon. If we zoom in into the tendon, we see what? Can you guys see here? These flattened nuclei. Now these flattened nuclei are again what? Fibroblasts that secrete what? Collagen fibers. Now collagen fibers here are even more than the dense irregular. That's why it's a lot more dark. Okay. Then we have elastic fibers. Now this is your aorta. It's a cross section of the aorta. And when you zoom into it, can you guys see these black lines? These black lines are what? Your elastic fibers. Now, elastic fibers are kind of like a rubber band, so they stretch, okay? And of course, we need the aorta to stretch, so it has a lot of elastic fibers. So they provide what? Elasticity. So they are for stretching or distension. Okay, then before I start with muscles, any questions about connective tissue? They won't ask you to point where the fibroblast is, but in the microscope there will be an arrow, okay, or in the picture itself on the paper there will be an your thing is digital. Okay, in the picture there might be an arrow pointing towards the nucleus. Wait, let me go back to it. Yeah, exactly like this. Can you guys see this black line? There will be a black arrow pointing towards the nucleus. Okay, and that nucleus is of the what? Fibroblast. They'll ask you which type of cell is found here, and you would say fibroblast. They might ask you what is its function? Secreting what? Collagen. So one has more cells? It's not about which one has more cells. It's about which one releases more collagen. Okay, so first we had loose areolar. That is the least amount of collagen. Then we have loose areolar is also called loose irregular. Okay, then we have dense irregular, which has more collagen. And then, of course, we have dense regular, which has the most collagen. Can you repeat the adipocytes? Sure. Okay, look. So in adipocytes, we said the slide will look faint, like it will look all white with thin rims, okay? Like, can you guys see this? All of these are just adipocytes, okay? Now, adipocytes are basically cells of fat tissue or adipose tissue, okay? Adipose tissue is for insulation or cushioning of organs, okay? To protect the organs or to insulate them, okay? Keep the temperature, like, keep the body's temperature stable for insulation, okay? And we said that the cells have like a thin rim around them, like the wall is really thin, okay? You guys can see that on the slide, okay? And the cell itself looks empty. It looks like there is nothing in there, but actually there was fat, but it got washed off when we were preparing the slide. So that's it for adipocytes. What happens if you mess up the spelling? Usually it's fine if the word is still like, if they can still understand what the word means, it's fine. But if it changes the word's meaning completely, then no, they won't accept it. Do we have to know reticular fibers too, or just elastic and collagen? No, reticular fibers, just know that they are there. Like wait, let me go back to the slide. Wait, where was it? Yeah, here. Here we have reticular and elastic fibers along with collagen fibers. Okay, but you don't really have to know what reticular fibers are. Dense regular CT has the most for anything I say here is for OSPE only, and don't take my word for any MCQ question. Okay, dense regular CT has the most fibroblasts. You can say that, yeah, fine. The most fibroblasts with the most amount of collagen fibers. Will we identify reticular fibers? No, because you can't really see them. You'll only be asked about collagen fibers. However, elastic fibers, yes, you will be asked about them. Is the function of dense regular CT to resist tension in one direction? The function of dense regular wasn't mentioned in your lab slides, so they won't ask you about it in OSPE. But if they do, yeah, you can say to resist tension. That's why they are found in tendons of muscle. By here, do you mean the adipocytes? Here, nucleus is on the side. If you mean the adipocytes, then yeah, the nucleus is usually pushed to the wall, like towards the side. Okay, how do we know it's elastic fibers? Let me go back to the slide. Can you guys see how dark it is? Like there are black lines. and elastic fibers are always black. They're always going to be black. Okay. Do you have to know the subtypes of collagen? For OSPE, no. For MCQs, yes. Okay. Any more questions? Okay. Now for muscle, let's start with skeletal muscle. Now, how to identify that this is muscle? First, you're going to look for striations, okay? And striations are really visible on this slide here, the blue one. Now, can you guys see these vertical lines? Let me zoom in. Yeah, can you guys see here? These vertical lines are called striations. Now, these are what like tells you that this is a muscle, okay? Now, how do we know it's skeletal muscle? One, it's going to be multinucleated, as you guys can see here. It has more than one nucleus, okay? And the nuclei are going to be pushed towards the edge, like towards the side. Can you guys see here in the transverse section, in the cross section? This is the muscle cell, and the nucleus is here towards the edge, again here. This is called peripheral nucleus. طيب, so peripheral nuclei are what tells you that this is skeletal muscle. Striations are what gives off that it's a muscle, okay? Next, we have cardiac muscle. Here, the nuclei are not peripheral, they are centrally located, okay? So they are in the center of the muscle fiber. Again, we have striations because this is muscle tissue. So here are striations. However, what gives off that it's a cardiac muscle is this right here. Can you guys see this thick line? Thick vertical line. This is called intercalated discs. Okay, so these are what? Your intercalated discs. They are only in cardiac muscle. And the nucleus here is in the center of the cell. It's not towards the edge. Like look here. In skeletal muscle, the nuclei were towards what? Towards the periphery. Okay, like here, you can see it towards the edges. But in cardiac muscle, it's what? In the center. Okay. Also, can you guys see here these two cells labeled A and B? Okay. Now, this isn't usually seen in skeletal muscle. This is only seen in cardiac muscle. Here, they branch and then they join together again. Okay. Can you guys see the space between them? That is where A branched and B branched, and then they joined here on the sides. Okay. Now, this is like, this has a reason. And that reason is for the heart to contract at the same time, for all the muscles of the heart to contract at the same time. Now, this is called what's syncytium, okay? And what allows the heart to like contract at the same time is these intercalated discs that are found between the branching and anastomosing fibers. What does branching and anastomosing mean? Branching, splitting off into two parts. Anastomosing, connecting again with the cell next to it. So cell A here branched, and then it anastomosed with cell B. Okay, and between them, you guys, I don't know, guys, if you can see it, but these are your intercalated discs here. Okay, but they're quite visible here in the H stain. These are your intercalated discs, and they allow the heart to be what? A syncytium. Syncytium means it contracts all at the same time. Okay, and then we have our third type of muscle, which is smooth muscle. Now, smooth muscle is quite hard to identify. However, you're just going to see, like, can you guys see these faint nuclei? I don't know if you guys can see them, but this is what you're going to see like in the slide. It kind of looks like waves. Now, these waves are fusiform cells. Okay, so the cells are not flat. They are flattened. However, they are fusiform means like they're tapered at the ends. So they're thin towards the end here. Okay, but thick in the middle. Like, can you guys see how thick it is in the middle? And then towards the end, it kind of looks like an eye. Okay. Like, look here. It's like this, and then like this. And then here we have our what? The nucleus. Okay. Now, these were your fusiform cells, which are only found in what? In smooth muscle. Okay. And also here, the nucleus is centrally located and it's not towards the periphery. Okay, so here are another like different type of slides all together. Skeletal, cardiac, and smooth. Now, we weren't able to see smooth in the earlier slide. Now, this is what it looks like. Can you guys see it? It's fusiform shaped. Okay, and the nuclei are what? Centrally located. Same thing with the cardiac cells. The nucleus is centrally located. Okay, and here you can see the what? The intercalated discs. And then in skeletal muscle, it's just striations, and the nucleus is what? Peripheral, towards the edges. Okay? So any questions? You don't really have to know about syncytium, but just telling you guys so that you guys understand why we have the intercalated discs. But they might ask you about it in MCQs. However, in OSPE, they don't usually ask about it. You can't really see intercalated discs in cross-section because it's so thin, like you can't get an exact cut at that point. What do you mean by bands? Oh, no, no, no. You don't have to. But know them for the lecture, for the MCQs. How do we differentiate between cardiac and smooth and cross-section? Okay, smooth. Can you guys see here? Cardiac muscle are like each layer, each cell is like split. Okay, but smooth, it's a lot more smoother, if I may say. Okay, like they're all like together, clumped up together. But they won't ask you to differentiate between them in cross-section because it's really hard to. They're usually going to give you a longitudinal section, and in longitudinal section they're quite obvious. Smooth cells are fusiform, cardiac cells have intercalated discs. More connective tissue in smooth. Are you asking or answering? Oh, more connective tissue in smooth. Yeah, 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 yeah. But you don't have to, again, you don't have to know that for OSPE. Okay. Connective tissue is whatever is between the cells. That is called connective tissue because it connects. So whatever is between the cells is called what? Connective tissue. Okay. But here the main things are, we said for skeletal, peripheral nuclei with striations. Okay. And for cardiac, we said what? Centrally located cell nuclei with intercalated discs. And then for smooth, fusiform cells. Okay. Now for neurons. Okay, so we have our first type of neurons are called multipolar neurons. Okay, now these are found where? In your spinal cord. Okay, now multipolar, so it has what? More than one process. Okay, so 1, 2, 3, 4. Okay, and can you guys see here this dark dot in the middle? Now that is your nucleolus. It's not the nucleus. Okay, the nucleus is what is around the nucleolus itself. And then around that, the dark part, now the lighter part around this dark dot here. So this is your nucleolus. The light part around it is the nucleus, okay? And then around that, the darker area is called what? Nissel's bodies. Now, Nissel's bodies are basically rough endoplasmic reticulum with polyribosomes or ribosomes, okay? And then these cells around it are your glial cells. These are there for support, okay? So what? Multipolar neuron, Nissel's bodies. It has the nucleolus in the middle with the lighter nucleus around it. And then what? more than one process. And they are found in your spinal cord. Okay. And if they ask you, of course, they transmit nerve. They transmit nerve impulses. Yeah. Now we have gray and white matter in the spinal cord. Okay, so in gray matter, if you zoom in, this is what the multipolar neuron looks like. Okay, so it has the nucleolus here. Okay, and then we have Nissel's bodies again, and we have the lighter nucleus around it. However, here the cells surrounding it are not just glial cells. This is called neuropil. Okay, it's a mix of processes that come out of the cells and glial cells. So it's called what? Neuropil. So in gray matter, we have neuropil with the multipolar neurons, which have what? A nucleolus, a tiny nucleolus here, and then around it is the nucleus, and then surrounding the nucleus is what? Nissel's bodies. Okay? This is it for gray matter. Now for white matter, we can see the axons here. Okay? These pink cells. Can you guys see here? This is your axon, and then the white surrounding the axon is what? Your myelin sheath. Now, what is myelin sheath? It's kind of like a fat layer that wraps around the axon. Okay. Now, why is it wrapped around the axon? One, insulation. Two, for faster nerve impulses. Okay. Now, again, remember how we said adipocytes look white, okay, under the microscope? Again, here, myelin sheath is made up of fat, so that's why it looks white, because it got washed off when we were preparing the slide. Okay, so the only difference here is we can see the axons, okay, and surrounding the axons we have what? Myelin sheath. And this is your white matter. Gray matter was the one before it here. So can you guys tell the difference? So white matter kind of looks like it's emptier than gray matter, okay? Then we have peripheral nerves. Now this is a longitudinal section of peripheral nerve, okay? And this is a transverse section here, okay? So in the longitudinal section, you guys can you guys see this thin line here? This thin line is your what? Your axon. Now, whatever is around the axon is what? Your myelin sheath. Now, what makes this myelin sheath is this cell here, which is called what? The Schwann cell. So the nucleus is for the Schwann cell, wrapped around the what? The axon. And this thing that is around the axon is called what? Myelin sheath. Now, this here is one myelin sheath or one Schwann cell. And then here is another Schwann cell or myelin sheath. Between them, this area is called node of Ranvier. Okay. Now, these nodes of Ranvier their function is saltatory conduction. What does that mean? It means that the nerve impulses jumps in between the nodes of Ranvier. This makes the nerve impulses move faster. Now, this is called saltatory conduction. Okay. So if they ask you, they point towards this and they ask you, identify nodes of Ranvier. Function, saltatory conduction. Okay. So axon, myelin sheath around it. The nuclei here are for what? Schwann cells. Now for the cross section. The cross section is only for you to identify the layers of the thing that wraps the neurons. The first layer is called what? Endoneurium. Now, can you guys see here? This is one cell. Around it is endoneurium. Okay, endoneurium wraps one neuron. Okay, then perineurium wraps a bundle of neurons. Can you guys see here? Around each bundle is what? Perineurium. And then these bundles are again wrapped together by epineurium, which is the outermost. We said epi means outermost, so epineurium. Okay. Now again here, can you guys see this? In the middle of the cell, we have in the middle of myelin sheath, we have axon. We have the axon. Again, myelin sheath appears clear. Okay. And then the nuclei, the big nuclei are for Schwann cells. Is that clear? Before I move on, do you guys have any questions? Do you guys want to take a short break? Okay, we'll take a 5-minute break and we'll come back. Okay. Okay, so we're starting again. Okay. So unipolar neurons and satellite cells. Now, this is what the slide is going to look like. The first one was multipolar. So it was more than one process. Here it's just one axon, unipolar. Okay. Now, how to identify this? There. Okay, wait, let me go back. Here in multipolar, we saw that the cells had what? More than one process. But now it's just one. Okay. Now it's this unipolar neuron has a what? A nucleus. Again, this dark point here is called what? The nucleolus. Around it, the light area around it is called the nucleus. Okay. And the body is round. And then around them, we have what? Satellite cells. Can you guys see these cells around it? These are your what? Satellite cells. Okay. Now these are for what? Just again for structure and metabolic support. Nothing else. Okay. So satellite cells, they are around the neuron. Okay. And they provide structural support and metabolic support. Okay. This is just identification. Okay. Now question. That is it for the entirety of general histology. Do you guys have any questions? How to differentiate between what is nodes of Ranvier and no, they're nodes of Ranvier are in neurons. Intercalated discs are in cardiac muscle. I'll show you it right now. 1 minute. These are your intercalated discs. Can you guys see the striations, the centrally located nucleus, okay, and the intercalated discs in the middle, okay? However, for the neurons, there are no striations. There is nothing, okay? It's just the nodes of Ranvier. That's how you can tell the difference. Unipolar and multipolar. Okay, unipolar, it means that it's just one pole, one long axon, okay? Multipolar means that it has more than one axon. So look here, multipolar has how many processes? Look, 1, 2, 3, 4, okay? So it's more than one pole, so multipolar, okay? And it kind of looks like a star. But here, in the unipolar, it's just one, okay? So it's one axon, one long axon. That's it. Uni 1. Polar means pole, like it has only one pole. This process means pole. Here. Can you guys see this? These P's. It means it stands, that's why it's called multipolar. Repeat what exactly? Okay, unipolar. Okay, so your unipolar cells, unipolar neurons, it's basically a neuron that has only one long axon. Okay, so this in the middle here is your what? Your axon. Okay, and around it is what? The Schwann cell. Okay, the satellite cells, sorry, satellite cells, which are for what? Structural and metabolic support. They're not going to ask you about details in OSPE. It's just identification. Okay, so this is what unipolar neurons look like, and the ones that look like stars are multipolar. Okay, pseudo unipolar. This wasn't mentioned in your OSPE. Maybe it was mentioned in the lectures, so it's not in your OSPE. In your OSPE, it's just unipolar. Any more questions? Can you tell by stains? I mean, you can memorize the slides, yeah. Memorize the slide for identification only. But you can't tell them that this is a differentiating feature. You have to know like features to differentiate between them. Okay? So memorize by stain, yeah, for you to know. But in the exam, you can't tell them that it's blue, so it's multipolar. Okay? Any more questions? Okay. So I want you guys to solve this question. Name the type of epithelium shown and state its function. Stratified squamous keratinized epithelium. And function? Protection. Yes. And now for hematologic and morphology disease with Leen.
Okay, guys. Actually, before we go through this, I just want to make a quick correction towards the jugular vein thing. Okay? I corrected the slide here. There's no like jugular vein. Like I double checked. I just had like a wrong classification. But you have your left external jugular vein. It drains into the left subclavian. And the left internal jugular vein joins together with the left subclavian to become the left brachiocephalic vein. So that's the only point I wanted to make. The slide is corrected, and inshallah we'll send you the updated slides soon. Okay. Now let's begin with hematologic, morphology, and disease. Hold on. Right jugular vein though, it's the same thing on both sides. Okay. So let's talk about the morphology and disease. But before that we talk about the disease, let's talk about the morphology of the cells. So cells, okay? We're gonna start with reticulocytes. Reticulocytes are basically like I think it's the immediate precursor of erythrocytes, okay? It's the precursor of erythrocytes. So they're anucleate, they don't have any nucleus, and they have remnants of DNA, like this like blue thing is just remnants of DNA inside, and something called supravital staining. You just have to know the name of the staining. You don't have to know what supravital is or what the staining procedure is, just supravital staining. That's how you can see reticulocytes. And now that we talked about the precursor, let's talk about the actual cell, which is erythrocytes. Erythrocytes are these like red cells that you see over here, okay? They're biconcave in shape, which means that they are like, like they have like a depression in the middle, okay? And they're like biconcave, and they're anucleate. They don't have nucleus, and they lack most organelles, okay? And they're rich in hemoglobin. That's all you have to know. Hemoglobin is what gives it its red color over here. So yeah, erythrocytes, okay? Next, we have megakaryocytes. Megakaryocyte is a precursor of platelets, okay? So megakaryocyte is just literally a large purple haze. It's a haze. It's like it's like you threw purple powder in water. So it's just a haze, and that's how it looks like. So if you see like this large thing, that's a megakaryocyte from the name mega. Okay, platelets. Platelets, okay, you see these RBCs here? Next to them is you have these small like little debris. So this is small debris around RBCs. We call these as platelets. Platelets compared to the megakaryocytes is very small, okay? And they lack in nuclei, and they have granules, okay? What about band cells? Band cells are the precursors of neutrophils. Okay, they have a kidney-shaped nucleus. So as you can see here, this is the band cell. and here is the nucleus. It's just one nucleus that looks like a kidney. And you have presence of granules because, as you know, neutrophil is a granulocyte. And it's basophilic. It's purple. Okay. Neutrophils is very easy to identify, okay, because it has polysegmented nuclei, 3 minimum, 5 maximum, okay, 3 to 5 lobes. So here's 3, 1, 2, 3, 1, 2, 3, okay, and they have granules. You can see dots like in the cytoplasm. These like dots, these are all granules, and neutral stain. It's neither basophilic and it's neither eosinophilic. It might look a bit purplish, but from the name neutrophils, neutral. Eosinophils, okay, eosinophils, they have bilobed nuclei. They have 2 lobes. طيب. 1, 2, 1, 2, 1, 2. And from the name eosinophil, so it has an eosinophilic stain. It's pink, okay? So it's mostly pink. And you have the presence of granules. They're granulocyte. Basophils are very easy to identify. They're actually bilobed, but you can't see that. Like there's no point in saying it's a bilobe because you can't see that. Because there's a heavy amount of granules, and they're very dark. They have a basophilic stain. They're very dark purple. So you see this like very dark purple like granules. That is a basophilic. That's a basophil. Okay, lymphocytes. Lymphocytes has 1 nucleus. As you can see, there are no dots, so that they don't have any granules. Okay, so absence of granules, and they have a circular nucleus and a clear cytoplasm. Circular nucleus, clear cytoplasm, no granules. That's your lymphocyte. Monocytes have a clear bluish cytoplasm. It looks kind of blue. And how do you differentiate a monocyte from a lymphocyte? The monocyte has a kidney, like a kidney bean shaped nucleus. Kidney shaped nucleus. It has like an indentation over here. That's a monocyte. And once again, you don't have any granules. Okay, now we're done with all the cells. Do you guys have any questions regarding the cells? Or remnants of RNA? I'll double check with your lab slides on that, but you should make sure like with your lecture slides. Okay. Okay, inshallah we'll update that. Is there any other question? Yeah, follow your lecture content if it says RNA. Is there any other question? Perfect. Okay. طيب. Now that we finished with that, let's get into the disease. طيب. First disease is neutrophilia. As you can see, you have lots of neutrophils in this slide, okay? Neutrophilia, طيب, just means many neutrophils at one site. The biggest like indication to neutrophilia or mature neutrophilia, it's bacterial infection. Whenever there's a bacteria, like there's an infection, you'll see neutrophils like the first ones there. And then you'll see inflammation following that. Immature neutrophilia, it's basically many immature neutrophils at one site, and you could either have that in severe bacterial infection or chronic myeloid leukemia. So this is how immature neutrophilia looks like. Severe bacterial infection or chronic myeloid leukemia. How do you know this is an immature neutrophilia and not like mature neutrophilia? As you can see, like the lobes here are not properly like they're not segmented yet. Some of them are segmented, and that's how you know it's a neutrophil, but some of them are still developing into a neutrophil. You can see a band cell over here, for example. So this is immature neutrophilia. Severe bacterial infection, chronic myeloid leukemia. Okay. Then we have eosinophilia. Eosinophilia means that you have lots of eosinophils at one particular site. Okay, so many eosinophils at one site. Famous indication would be allergic reaction and asthma, and also allergic reaction. So you can have parasites, asthma, or allergic reaction, but most likely parasites. They'd always give you guys parasites because you also have basophils, which are in allergies. Basophilia. This is very important. It comes a lot in every single exam. Basophilia. Okay. Chronic myeloid leukemia. CML. Always in every single exam. It always comes. Monocytosis. You have lots of monocytes over here. And this is an indication of mycobacterial infection or chronic infection. When you have an infection for a severe, like long time, that's monocytosis. Mature lymphocytosis is when you have lots of lymphocytes at one site, and they're all mature. You see, they're typical lymphocytes, nothing's wrong with them. And this is when you have infectious lymphocytosis or CLL, chronic lymphocytic leukemia. This is also important to memorize. Then you have reactive lymphocytosis. Now, reactive lymphocytosis differs from mature lymphocytosis because reactive, it looks different. Like if you see like mature lymphocytosis, it's like just a normal lymphocyte just multiplied. But here it has like a shape over here. It has a different shape over here. So it's atypical lymphocytes. Where do we find this? In infectious mononucleosis, which is caused by the EBV virus. Please remember this full name. Infectious mononucleosis caused by the EBV virus. Cytoplasmic vacuolization is basically when you see many holes in the cytoplasm of a cell. Okay? Many holes in the cytoplasm. When do you see this? When the cell is actively fighting infection, and you see toxic granulation. Toxic granulation means that there's so much granules, and that usually happens when the infection is becoming severe. Left shift neutrophils. Left shift neutrophils just means toxic granulation of the neutrophils. This is toxic granulation. You have so many, the granules are very prominent here. And that's not normal because that means that the neutrophil is fighting infection. Okay, now this slide, guys, 100%, if not 100%, 99.9% it will come in your exam. Our rods, okay? Our rods. It's basically rod-like structures that are right over here in the cytoplasm of a myeloblast. Every time you see a rod, that's an hour rod, and that indicates acute myeloid leukemia, AML. Please don't forget this. AML. Before I go into the anemias, any questions? Neutrophilia means increased amount of neutrophils. If it's chronic, it can be a disease. And CML, I double checked on your group chat. I think Dr. Rehan emailed you guys that it can be in both. Okay, CML and AML, the difference, honestly, is just acute myeloid leukemia and chronic myeloid leukemia. It's just one is acute, short time, chronic, long time. And you don't have to know the difference for OSPE. So I suggest you go back to your lectures for that. Neutrophilia is just an increase in neutrophils. Right shift, I'll tell you what's right shift neutrophil in a bit. But left shift neutrophils is toxic granulation. It usually happens in neutrophils, but I'm not very sure. Cytoplasmic vacuolization, I'm not very sure if it happens in other cells, but I can double check on that and let you know. Okay, let's get into the anemias. This is a very important part of the lecture. Okay, anemias are very important. This is iron deficiency anemia. How do we know this? Because it's microcytic, low MCV. That means that the cell size is all low, and hypochromic, low MCH. That means the color is kind of washed out. Remember how I showed you guys the erythrocyte? It was very red. This is just washed out. What do you see in iron deficiency anemia? You see elliptocytes or pencil cells. This is an elliptocyte. This is an elliptocyte. This is an elliptocyte. Okay? You could either say elliptocyte or you could say a pencil cell. Because they look like pencils. Okay, so yeah, you can also see teardrop cells. Teardrop cells, let me find one here. Okay, this is a teardrop cells. It looks like a teardrop. This is another teardrop cell. Okay, this is another teardrop cell. So it just looks like a teardrop. You can also see anisocytosis. Anisocytosis basically means that there's like difference in sizes between all of the cells. Usually RBCs are similar in size. So here you see anisocytosis and low reticulocyte count. Indication, iron deficiency from the name. Like megaloblastic anemia, okay, macrocytic, high MCV. Remember from your lectures in Numafi, there's no what's it called, like high MCH. There's only high MCV, so it's only macrocytic. It's hypersegmented neutrophils. This is what I meant by right shift. This is whoever was asking what's the difference between left shift or right shift. Left shift, toxic granulation. Right shift, hypersegmented neutrophils, more than 5 lobes. Here you have 1, 2, 3, 4, 5, 6 or 7 lobes. So that's right shift neutrophilia. And you also see some anisocytosis. And indication would be vitamin B12 deficiency and folic acid deficiency. But sickle cell anemia. Sickle cell anemia is also very important. Okay. You see sickle cells, obviously. These are the sickle cells. Okay, they look like a sickle. They are spindle shaped. Okay, and they look like a sickle. And you can also see target cells. Now, target cells or cells, let me find one. This is a target cell over here. It's like a circle and there's a dot in the middle. And that represents like a target, like the bow and arrow target, you know? So that's why we call it target cells. So target cell, target cell, target cell. Okay. Then we have teardrop cell. Teardrop cells, as I showed you guys, this is a teardrop cell over here. You can probably find more. And anisocytosis. But indications, genetic substitution of glutamate to valine. طيب. Aplastic anemia. Aplastic anemia, طيب, there's not like a real clear indication, but the indication that's over here, and no, there's not a lot of RBCs. You don't see a lot of RBCs. And you don't see a lot of WBCs, and you don't see a lot of anything. Why? We call this pancytopenia. You have a low count in all types of blood cells, RBCs, WBCs, platelets, whatever. So as you can see, like this smear looks very empty. Like there's just a couple of RBCs. And it has an empty marrow. This is the bone marrow. It's hypocellular. طيب. It doesn't have a lot of cells. And a few hematopoietic stem cells. The marker for that is CD34 in bone marrow. Just know, like it's a few stem cells in the bone marrow. Indications, it's idiopathic. Idiopathic means that there's no known cause to what causes aplastic anemia. It just occurs spontaneously. Okay, thalassemia minor. Honestly, all you need to know, it's microcytic, hypochromic. This is how it looks like, microcytic, hypochromic. It's genetic. It's low-key kind of low yield, but it does come in exams, especially this picture, it does come. But the very, very high yield that came in every single exam, it came in the summer exam, it came in our exam, it came in 16th batch, 15th batch, everything, is this yellow picture. And this yellow picture is thalassemia major. طيب, what do we see in thalassemia major? Is anisocytosis, different sizing, poikilocytosis, which means different shaped cells, and nucleated RBCs. So you see these are RBCs actually, but they have a nucleus, which is not normal because we said RBCs don't have nuclei. Indications, genetic. So other things that you can have that can go wrong, okay? You have schistocytes and rouleau formation. What is a schistocyte? A schistocyte is basically a fragmented RBCs. And the common cause would be hemolytic anemia. This is how it looks like. So you see the RBC here, sometimes you can like cut it through and it becomes fragments. It gets cut into fragments over here. طيب. Rouleau formation basically just means stacked up RBCs. So a common cause would be high antibody count or IgG. And this is how it looks like. You just see a bunch of RBCs stacked up upon each other. And that's it. Before we go to the question, let me see if you guys have questions. Did we take the first one? Schistocyte. I found it in your lab thing, your lab sites. Aplastic anemia, same as hyperproliferative anemia? Yes. According to Dr. Rehan, it is. Okay. I think I found it in your lab guide. Honestly, guys, this also did not come طيب to us as well. بس يعني I found it in your lab guide and I tried to make it as complete as possible just in case. In your morphology, it said that you need to know what's a fragmented RBC. So if you don't remember the word schistocyte, at least say fragmented RBCs. Misleading low RBC count in CBC. I do not know, honestly. And you do not need to know that for your OSPE. But if it's included in your slides, then you could ask Dr. Rehan. What is the difference between thalassemia major and minor morphology? طيب. Okay. I can't lie, they look kind of similar, but the thing is here you see poikilocytosis. Look, like here, like the RBCs like kind of look different. Some of them. طيب. Here they all look the same, it's just they're all small. طيب. يعني maybe you can see a few teardrop cells here and there, but it's like it's just all similar size and similar shape, but just they're just small and they're hypochromic. Microcytic hypochromic blood cells. بصراحة, I do not remember because this is a lecture material, not lab material. I believe that you can go back to your lectures for that. Okay. Does everything make sense? Okay, that is okay. Does everything make sense? Okay, alhamdulillah. Okay, now let's test your knowledge, guys. You do have lymphatic histology. We're going to cover that soon, inshallah. Don't worry. Basophil. Nice, guys. Okay, and give one reason. CML. You're absolutely correct. Inshallah, you guys are very smart. Okay, blood grouping with Rahim.
Okay, so blood grouping. First, you have to understand what blood grouping is. It's basically classifying different blood types, okay, based on antigens that are found on the red blood cells, okay? Now, antigens are like proteins that identify a cell, okay? So they are what identify this RBC, either as type A, type B, type O, okay? So we have two systems, the ABO system and the RH system. ABO is basically what tells us this is type A or type B or type AB or O, okay? And the RH system tells us whether it's positive or negative, okay? Based on an antigen called what? The RHD antigen, okay? If the antigen is present, it's RH positive, okay? Now type A, in blood type A, we have the antigen A. However, the antibodies of that blood type are against the B, okay? So it's anti-B antibody. The antigen A, anti-B antibody. If it's type B, then the antigen is B. However, the antibodies are anti-A, against the A, okay? Now type AB has both A antigens and B antigens, but it has no antibodies. Why? Because it has both antigens, so it can't attack another antigen, okay? It can't attack one of its own antigens. That's why it has no antibodies. However, type O, it has no antigens, so neither A nor B. However, the antibodies attack both A and B, okay? Now, this is what tells us who can give whom blood. So type A can give everything with A, okay? Type O can give everyone, okay? Type B can give anything with B, okay? And type AB can only give AB. And for the positive and negative, positive can only give to positive. However, negative can give to everyone. Okay, so now let's explain this on this table here. Now A plus A positive, okay? So A can give to A's. So A positive, A negative, AB positive, AB negative, right? However, because it has positive, so it can only give to the positives with A in them. So A positive and AB positive. It can give to A negative or AB negative. Okay. Now we said O gives everyone. Now it gives everyone means including the negatives. But because we have positive, O positive, that means it only gives everyone that has positive. However, since O gives everyone and negative gives everyone, that means O negative gives who? Everyone. Okay? But it can't take from anyone. It only receives from O negative. Why? Because O has antibodies against both A and B. Okay, so if you give someone with O negative blood, any other type of blood, their body is likely to attack the blood that entered their system. Now, a quick note. In our OSPE, they asked us about which sugar A and B were made from. Just know that type A is made from a sugar called N-acetylglucosamine. Okay, so N-acetylglucosamine has an A, so type A. And then B, galactose. Okay, so type B is the shorter one, galactose. Type A is the longer one, N-acetylglucosamine. Okay, but you have to know the names. They'll ask you to write down the name of the sugar that it's made from. Okay, now how will you guys be asked about this? They can either give you a tile or a gel card, but you have to know how this tile is prepared. Okay, so this is the preparation for it. So a tile, it's basically like, it has wells on it or like tiny discs here. Okay, they're going to be empty, but each disc, you're going to add either anti-A, anti-B, or anti-D. Okay, now these are what? These are called anti-serum. Okay, anti-serum, so they are antibodies against the antigen. Okay, and you have to know, by the way, that anti-A is the blue one, anti-B is the yellow one, and anti-D is the gray one, because if they ask you about it, they're probably going to cover the labels. Okay, so the blue one is anti-A, the yellow one is anti-B, the gray one is anti-D. Now you're going to take a drop of anti-A and put it in the first well, and then a drop of anti-B and put it in the second well, and a drop of anti-D, put it in the third well. Okay, and then you're going to get the patient's blood. Okay, and you're going to put it into each well. Now, whenever it's a positive result, it's going to clump up. That is called agglutination. So the results here, agglutination means positive. No agglutination and it remains as it is, that is a negative result. So anti-A will attack what? The A antigen. So if the patient has A antigens or has blood group type A, you're going to see clumping here. So A has clumping here. But because it doesn't have type B, so nothing happens in the anti-B serum. And because he's A positive, the anti-D is also going to clump up. Okay, so let's take another example here. For example, AB positive. Now, AB has both A and B, so the antibodies and the anti-serums that we have in the wells are going to attack what? The antigens that are found on the patient's blood. Now, when they do that, they're going to clump up together, and it's going to give us a positive result for anti-A, a positive result for anti-B, and that means it's AB. Whether it's positive or negative, here with anti-D. If it clumps up, that means it's positive. So AB positive. Okay, now next up, we have the gel card method. Now, there are two parts to this method. First part is on the left, and the second part is here. This is called forward grouping. This is called the reverse grouping. Okay? No, actually, this is not the one. It's here. This is called forward grouping, and this is reverse grouping. Okay, so forward grouping is for you to find the antigen, okay? It's for us to know the blood type. Reverse grouping is for us to make sure by cross-checking with the antibodies that are found in the patient's blood. Okay, now what does that mean? Let's see an example here. So before you guys solve the question, they're going to give you a gel card and they'll ask you what blood type it is. Before you solve the question, you have to read the label. Okay, it says here A and B. So this is anti-A and this is anti-B. Again, here it's A and B. So here, we don't have the reverse grouping part. It's just the forward grouping repeated twice, okay? Just to make sure that the results are accurate. So a positive result here would show an agglutination. Agglutination here means that the clumping is floating, okay? So the clump is floating here. However, if it goes down, that means it's a negative result. That means the blood just went through the serum and nothing happened to it, okay? Through the antiserum. So here, because it clumped up and it's floating in A, that means it's positive here. And here it's negative. So what blood type this is? Okay, someone said A positive. Now, this here, it's not A positive. It's only type A. Why? Because we don't have the D, the RHD. It's only A. We can only tell whether it's A or B using this method, or this card specifically, okay? Because we said here, it's what? It's only forward grouping. We don't have the RHD factor. This one is a control and this one is a control, okay? Controls are basically there to tell you that the kit is working, okay? So here, it's positive with A, but it's negative with B. So it's type A. Neither positive nor negative, okay? I'm not sure if they explained to you guys on this exact card, but this is the card that they used in the slides, okay? But I have another example. I'll show you guys it right now. And this is it, okay? Now here is where we have the D, okay? The RHD. So we have A, B, and D. If it's positive, then it's positive. If it falls down, it sinks to the bottom, then it's negative, okay? So yeah, the first example, it's repeated. Like the test here is repeated twice just to make sure it's working. But here it's not. Here we have the forward grouping on this side, and this is the control to make sure that the kit is working. And here is the what? The reverse grouping. Okay, so now, what blood type is this? Exactly, A positive. Why? Because here it clumped up and it's floating in A, and in B, it sinks to the bottom, so it's negative, so there is no B. And then for the RHD, it's positive, so it's A positive, okay? And just to make sure, we do the what? The reverse grouping. Now, the reverse grouping is to check whether he has, what type of antibody the patient has, okay? So because he has type A, blood type A, he's not going to have antibodies against type A because he doesn't want to attack his own blood cells. However, he has anti-B. That's why the test will be positive for B in the reverse grouping. So can you guys see this clump up here? And then in anti-A, it's going to be negative. Why are the B antibodies not? It just like stuck here up. Can you guys see it? Okay, can you repeat? Sure. So I'll repeat the first one. Here, there is no RHD. So we can only tell whether it's type A or type B. Okay. Here in the tube, we have what? The antiserum. Okay, the antiserum which has antibodies against A. And then the antiserum which has antibodies against B. So if it clumps up in A, that means you have antibodies against A in what? In the tube. So the patient has type A. Okay, the patient's blood is type A. All right, so this only tells you whether it's A or B. However, here we have the RHD tube. Okay, so he is type A because it gave us a positive result in A, but in B it didn't give us a positive result. So he's only type A. It's not AB, just A. And then RHD is also positive, so he's A positive. Okay. Antigens are in the blood. Like here in the blood, we have the antigens. Antibodies are in the serum itself. That's why it clumps up. They react together and they make the clump. Do you get that part? Okay, what about the last three? This one is a control. Okay, this is just to tell you that the kit is working. We're not usually asked about it. Okay, so it's there just to tell you whether the kit is working or not. And then here, this is the reverse grouping tubes, these two. Okay. Now, this has antibodies against A. Okay. No. This is to tell you whether the patient has antibodies against A. And this one here is to tell you whether the patient has antibodies against B or not. So if it was positive in this tube, that means the patient has antibodies against A. Okay, that's why it's negative here. Since he has blood type A, that means he can't have antibodies against type A. Or otherwise his body is going to attack its blood cells. Yes, that's why he is positive for antibodies B, anti-B antibodies. Is everyone fine with this? Someone asked about what will it look like if it's type O. If it's type O, both are going to be negative here, and both will be positive here for the reverse. So forward grouping will be both negative. A is negative, B is negative because it has neither A antigen nor B antigen. But because it has anti-A and anti-B antibodies, it's going to be positive in both the reverse grouping tubes. Okay? All right. So this here is type A and RHD is positive, so A positive. Now for everyone's least favorite part, lymphatics. Okay, so we're just gonna go over the general anatomy and then we'll go into the histology of it. So first we have regional lymph node. Okay, so a lymph node is basically where lymph passes through to get cleared up. Okay, so we have three lymph nodes that you have to know, regional lymph nodes. One, axillary lymph nodes. These are in your underarms. Okay, so axillary lymph nodes, and these drain what? Your upper limbs. Okay, and the head, of course. And then we have cisterna chyli, which drains your intestines. Okay, and it takes the lymph into the thoracic duct, which is here. I think you guys should know thoracic duct from your lecture. And then here at the bottom, we have inguinal lymph nodes. So inguinal lymph nodes are to drain what? Your lower limbs. And then it goes up here, okay? And the intestines are drained into the cisterna chyli, okay? And then both of them go into the thoracic duct, all right? And your upper limbs are drained by axillary lymph nodes. That's all I want you guys to know for now. Then the two ducts that we have, the thoracic duct, okay, which drains most of the body, okay? And then we have the right lymphatic duct. The right lymphatic duct only drains the upper right quadrant. So only the right side of your head, your neck, and your right limb, right arm, okay? So the upper right quadrant of your body, quadrant means like fourth, okay? So upper right quadrant is drained by what? The right lymphatic duct. Everywhere else in the body is drained by what? The thoracic duct, okay? Now, the right lymphatic duct drains here. It has to go back into the veins, okay? So it drains in this right venous angle. Now, this right venous angle is made by your right jugular vein and your right subclavian vein, okay? So can you guys see here, this junction between two veins? This is called the right venous angle. And can you guys see this white vessel here? This white vessel is the right lymphatic duct, okay? But the thoracic duct is drained by the left venous angle, okay? So it goes around here and it drains into the junction of them. Here it's cut and removed, but it's supposed to drain here, okay? So that it goes back into your superior vena cava. So thoracic duct drains the rest of your body. Right lymphatic duct drains the upper right quadrant of your body. And this is what it looks like here. So the drainage of the right lymphatic duct is for only this part of the body. The rest of the body is done by the thoracic duct, all right? And here's what it looks like, the drainage into the veins. So the right lymphatic duct drains into the right venous angle. However, the thoracic duct drains into the left venous angle. That's it for the anatomy part of it. Do you have any questions? Okay, now let's move on to the histology part. Okay, so if you guys see this slide, okay, just immediately put spleen. All right, it's basically like it has these follicles here. Okay, now these not follicles, they're called white and red pulp. Okay, so red pulp is the pink part, and white pulp is the purple parts. Okay, so any purple parts here, these purple circles, these are all called what? White pulp. Okay, now if we zoom in here, we can see that the spleen has a capsule around it. So this part is the capsule that is what covering the spleen. And this here is a blood vessel. Okay, this also here is a blood vessel. If you guys see any hollow tube with blood in it, that is a blood vessel. Okay, now this blood vessel goes into the white pulp. Okay, and it has this white pulp has white blood cells around it to kill all the bacteria in the blood. And then it goes into the red pulp. Why is it red pulp? Because it has blood in it. Like blood is spread around in it. And now we'll look into them like in detail. And what holds the pulp together is what? Reticular fibers. Okay? And these reticular fibers have macrophages around them. These are the four things that I want you to know. White pulp, red pulp, okay? The reticular fibers, and that's it. Okay? Also, the capsule invaginates into the spleen, okay, and forms this thing called trabeculae, okay? So trabeculae are what? They're basically invaginations of the capsule. That's it. They carry the blood vessel and send it into the white pulp. And then from the white pulp, the blood vessel goes into the what? The red pulp, where blood is like spread around. Okay, that's why it looks red. Now for white pulp, these purple parts are called what? PALS, periarterial lymphatic sheath. Okay, so they're basically lymphoid tissue. Lymphoid tissue that has what around them? T lymphocytes. Okay, and they have can you guys see here? It's really tough to see it, but it's an arteriole. This is called central arteriole. Okay, so central arteriole surrounded by T lymphocytes, which are white blood cells. Okay, and then this thing is called a periarterial lymphatic sheath. So periarterial, around the central artery. Peri, around, arterial, around artery. Lymphatic sheath, lymphatic because it's lymphoid tissue, okay, that has T lymphocytes. And then within the periarterial lymphatic tissue, we have the follicle, okay, which has B lymphocytes. And then this follicle, when activated, how will it be activated when there is an infection? Okay, when activated, it turns into something called germinal center. Okay, so this is a germinal center. Okay, that is it for white pulp. Now red pulp, we said it has blood. Okay, so it's composed of two things: splenic sinusoids and splenic cords. Splenic sinusoids are basically really tiny blood vessels that are quite loose, so blood can like easily leave them. Okay, now these sinuses, just know that they have staph cells. Stave cells. It was mentioned in your lab slides. I don't know if you're supposed to know it or not, but just keep it at the back of your minds. Okay, so the blood cells can easily leave the sinusoids because we said that it's loose. Okay, now in between these sinusoids we have splenic cords. Okay, and these splenic cords, they are just groups of cells like macrophages and white blood cells. Okay, also a clinical insight that was mentioned is in splenomegaly, because a lot of the blood is going to be flowing through the splenomegaly means enlargement of the spleen. Okay, so enlargement of the spleen, that means more blood is going to go into it. Since more blood is going to be going into it, more blood is going to be removed. So this leads to anemia because you'll have less blood cells, red blood cells. Okay, that was it for the spleen. Any questions about the spleen? You don't have to know what causes splenomegaly. It's just mentioned that in splenomegaly, there will be anemia. So can you explain the functions? Okay, so here, white pulp, okay, is they're both, the spleen is there to like clean up your blood. That's it. That's the general function. Okay. Here in OSPE, they only focused on identifying the structures for like lymphatics. So that's all you have to know. So periarterial lymphatic sheath is basically lymphoid tissue that has T lymphocytes surrounding the central arteriole. So the T lymphocytes are going to clean up the blood that is in the central arteriole. That is in the white pulp. Okay. Then when it goes into the red pulp, okay, it gets further like cleaned and processed, and then it can go back to the rest of the body. That's it. The black lines are the pal. No, the pals are these purple, purplish. No. Look, I'll show you here. Can you guys see this whole thing? This whole structure is called a pal. Pals. Okay. Actually, know the full name: periarterial lymphatic sheath. Okay, so it surrounds the what? The central arteriole. Yes, white pulp is the pals. But if you're asked to identify, mention that it's white pulp. Okay? Do you guys have any other questions? Okay, you can't see the central arteriole. Let me zoom in. So can you see here? This is your central arteriole. Okay, and then surrounding it, we have the what? The pals. So periarterial, around the artery. Okay, and then next to it, we have the germinal center. Germinal center is where we find B lymphocytes. So if they point towards this part here, this is your germinal center. And they'll ask you which type of cells are found in this B lymphocyte. However, if they point here, this is the lymphoid follicle. Okay. No, this is your pals, sorry. So periarterial lymphatic sheath, which has what? T lymphocytes. So pals, and then in the middle, we have what? The lymphoid follicle, which has the germinal center. Where are the nodules in the spleen? Can you point? These are pals. The pals is the whole thing. Okay. The white pulp, okay, with pals around the central arteriole. Central arteriole is in the middle. Okay, so it has pals around it. And then the germinal center in the middle is what has the B lymphocytes. Pals have T lymphocytes. It's better to write the full name, periarterial lymphatic sheath. And altogether is white. Yes, altogether is white pulp. Everything altogether is called white pulp. So everything in purple is white pulp. Everything in pink is red pulp. Okay, so this one right here, you can call it white pulp. And then if they ask you here, it's periarterial lymphatic sheath around the central arteriole. And then next to it, this lighter area, this is your germinal center, which has B lymphocytes. For these are pals. These are pals, like everywhere. These are pals. These are all called pals. Mantle zone is only this part. It's only this dark part here. Okay, but wait. Oh yeah, you can see also pals here. Can you guys see? All of this is pals. So the entire purple thing is pals. Pals plus the central arteriole plus everything around it is what? White pulp with the germinal center. So the red colored is pals. No, the purple colored is pals. Red, anything that is in red is blood, and it's called red pulp. Yes, white pulp is pals plus the central arteriole in the middle. Like this is your central arteriole, okay? And we have pals around it. All together, it's called what? Your white pulp. Okay, I hope it's clear now. Now, the red pulp is where we find the blood, okay? Because we said the splenic sinusoids are what? They have like spaces in between the lining of it, so this red blood cells can easily squeeze through them, okay? And we said in splenomegaly, we have anemia. Splenomegaly, anemia, all right? And don't forget that the red pulp is composed of what? Splenic sinusoids and splenic cords, okay? The sinusoids are where you see the blood, and the clumps around them, these purple clumps around them are what? Your splenic cords. Okay, now for the lymph node. Lymph nodes, you can identify them by seeing the cortex and your medulla, okay? So cortex is where you can find the what? These lymph nodules, okay? But first, from the outside, we have what? Again, the capsule. Just like in the spleen, we had capsule. Here we also have a capsule, okay? Now, again, the function of there, we said that the capsule is carrying what? The blood vessels. Again, here, the capsule is what carries a vessel. But this time, it's not blood vessels, it's lymphatic vessels, because this is a lymph node, okay? Here, lymph is being cleared. There, in the spleen, blood was being cleared, okay? So the outermost layer is called the capsule, okay? Then we have the cortex. Then we have a paracortex, okay? And then in the middle, we have what? The medulla, okay? So that is it for identification here. Oh, also, right below the capsule, we have this place called subcapsular sinus. Subcapsular, so below the capsule. So subcapsular space. So if they zoom in, okay, and they point towards this and they ask you what this is, you just tell them subcapsular sinus. They're probably not going to ask you about it though. Okay, so capsule, then after that we have the cortex here, and then we have the paracortex, and then these parts are called the medulla, which is the middle. Okay, so from medulla. Okay, now first we're going to start with the cortex. The cortex has germinal centers again. We saw these in what? In the spleen. Okay, so these germinal centers, again, they look light from the middle and they have a darker surrounding. Okay, now this darker surrounding is called lymphocyte corona. Corona means crown. Okay, so because it's round, it's called lymphocyte corona. Lymphocyte because it has lymphocytes. Okay, and there we said in the spleen, in germinal centers, we have B lymphocytes. Here we also have B lymphocytes, and here they're multiplying. Okay. Now, if there is an infection, these germinal centers are going to be activated and they're going to be prominent, and you can really see them. Okay, because the B lymphocytes are going to be activated. They're going to be attacking what? The infection. And then paracortex, it has T lymphocytes, okay, but it doesn't have what? The germinal centers. So if you can see the germinal centers, you're in the cortex here. If we go a bit towards the middle, then we are in the what? Paracortex. Labeled here are PCX, okay? So paracortex, T lymphocytes, no follicles. The cortex has germinal centers with B lymphocytes, not T, B lymphocytes, okay? Okay, so earlier someone asked me if we have to know reticular fibers. There in the connective tissue, no. But here in the cortex of the lymph node, yes, you have to know it because it's quite visible. Okay, it looks like cherry blossom trees. So can you guys see here? These are the reticular fibers, the black ones, and around them the cells, they kind of look like the cherry blossom tree. Okay, so they're only there to support this, like the cells, and hold it together. All right. And then we have the medulla, which is the central part of the lymph node. Now, in the medulla, we have medullary cords, which again, we said there, we had what in the spleen? We had splenic cords and splenic sinusoids. Here we have medullary cords, okay, which have lymphocytes, macrophages, and dendritic cells. So they basically have all types of cells here in the medullary cords. So wherever you can see like a lot of cells, clumped up together, that is the medullary cord. Where you can see spaces with red blood cells in them, it's what the medullary sinus. Okay, so wait, no, did I say red blood cells? I didn't mean that. Sorry. It's wherever you can see spaces. Okay, because here it's not red blood cells, because here it's only lymph. So in the medullary sinus, okay, it's between what? Can you see this? Medullary cord, medullary cord, medullary cord, and then in the middle we have medullary sinus, medullary sinus, medullary sinus. So wherever you can see spaces, that is the sinus. Okay. And we also have blood vessels. Can you guys see this? We said if you ever see a tube with a hollow space in the middle, that is what? A blood vessel. Okay. So these medullary sinuses, they all come together and they form one lymphatic vessel. Okay. But you can't really see that on the slide because it's a cross section. Okay, now high endothelial venules. These are really these are hard to identify, but if you really zoom in, okay, an arteriole has flat cells lining it. Can you guys see? But the venule, the high endothelial venule, has kind of cuboidal cells. Like, can you guys see? The cells are cuboidal in shape. All right, and this is a clearer picture. So the nucleus is quite big. It's not flattened. So that's how you can identify a high endothelial venule. Okay. So the lymphocytes, okay, in the blood enter the node by passing through the walls of the high endothelial venules. So here, the lymphocytes can pass through the wall. Okay. So for identification, high endothelial venules are what? Cuboidal in shape. The wall is cuboidal in shape. But the arteriole, it's quite flattened. Okay. Before I move on to the thymus, any questions? Black lines are reticular fibers, yeah. Lymphoid follicles, same as lymphatic nodules. Yeah, I guess you can say that, yeah, sure. Could we find cortex and medulla in other organs? Many organs have cortex and medulla, and I'm going to explain the thymus now, which also has a cortex and medulla. So cortex has secondary nodules. Yes, when it's activated, it becomes secondary nodules, yeah. Can you go to the which slide? Okay, this one, high endothelial venules. Okay, so for high endothelial venules, I only want you to identify them and like to differentiate between them and arterioles. Arterioles have flattened cells lining them, but high endothelial venules are lined by cuboidal cells. Can you guys see? The cells are cuboid in shape. All good? I also want you to know that high endothelial venules are in the paracortex, while arterioles are in the medulla. Don't forget that. Arterioles in the medulla, high endothelial venules are in the paracortex. And that's it. Now for the thymus, again, we have a capsule, okay? And however, this time the capsule gives off septa. Septa are basically kind of like trabeculae, but it has a different name. So in the thymus, the capsule gives you a septa that divides it into lobules, okay? And the difference between them is that trabeculae had blood vessels running through them, but septa doesn't have blood vessels, okay? Here, you guys can see that the cortex is quite darker than the medulla. We said that the medulla is in the middle and the cortex is the first layer afterwards, after the capsule. So here, the dark part is the cortex and the medulla is in the middle. Okay. Now, in the cortex, in the lymph node, we had what? Nodules, right? With germinal centers and whatnot. Here, we don't have that. We don't have any lymphatic nodules. It's just lymphocytes that are densely packed together. Okay. And the medulla is a bit more loose and like kind of spaced out. That's why it appears lighter. Now, how can you identify that this is a thymus? You guys are going to see this onion-shaped structure. It looks like a slice of onion. This is called Hassel's corpuscle. I think that is how it's pronounced. Corpuscles. Okay. So Hassel's corpuscles are in what? Are in the medulla. Okay, let me go back. Here, can you guys see these onion slices? These are Hassel's corpuscles. Okay. So they are basically reticular cells, but wrapped around, like the reticular cells wrap around each other. Okay, that's why it gives off the onion shape. And then around them, can you guys see these cells with large nuclei? These light purple cells. These are your epithelial reticular cells. Okay, this is also an identifying features. I don't know if you're supposed to know it for OSPE, but know it for your MCQ. It might come in a question. And again, we said any tube with blood in it is what? A blood vessel. So can you guys see here? Flattened cells. And then in the middle, we have red blood cells. So this is a blood vessel. So in the thymus, you're going to find Hassel's corpuscle. Now for palatine tonsil. Now, the palatine tonsil is non-encapsulated. So it doesn't have a capsule. So we only have an epithelium lining it. Okay, and the epithelium is a stratified squamous epithelium. We said stratified squamous epithelium means more than one layer. Squamous flattened epithelium, the outermost layer. So the outermost layer is flattened, stratified squamous epithelium. Okay. However, here it invaginates to give you what? Crypts, not septa or trabeculae. It gives you crypts. Now, why do we have crypts? Now, these crypts increase the surface area. That means we can, palatine tonsil is also a lymphatic organ. Okay, so it fights off infection. So we need to increase the contact between the palatine tonsil, okay, which has the lymphocytes, and the blood. Okay, so these crypts increase the contact between them. So they increase surface area for more antigen entrapment. Antigen of what? Of the organism, like causing the infection to kill it. Then we have here follicles, again with germinal centers. Can you guys see here the follicles? So far, the only one without follicles is what? The thymus. Okay. So palatine tonsil has follicles. The spleen has follicles. No, the spleen doesn't have follicles. It has white and red pulp. Okay. The lymph node has follicles. Okay. Now, again, the follicles in the middle, the lighter area, is called what? A germinal center. And that's it. Do you guys have any questions? Yes, it's non-keratinized. The distribution is random. Okay, spleen. What is it composed of? Okay, what is it composed of? I was supposed to make this question clear. This red area here, what is it composed of? The red pulp. Okay, so splenic sinusoids and splenicoids. However, if they ask you what the spleen is made up of, it's white and red pulp. You're right. Okay, so the organ is made up of white and red pulp. Okay, but the red pulp is made up of splenic sinusoids and splenicoids. Okay. Do you guys have any questions? So there are no reticular fibers in the thymus, right? Yeah. Do we need to mention keratinized? Yes. If there is keratin, mention keratinized if you can see it. it's probably going to be skin keratinized. So keratinized, squamous, simple squamous, no, stratified squamous, sorry. So keratinized, stratified squamous epithelium. Is this PPT enough for OSPE? Okay, so we tried to make it as inclusive as possible, but please refer back to your slides. So splenic cords and sinusoids. Splenic cords and sinusoids are what make up the red pulp. The follicles are within the white pulp, yeah. If you zoom in into the white pulp, let me go back to the... Okay, yeah, here. So in the middle of white pulp, wait, where is it? Yeah, in the middle of white pulp, we have this lymphoid follicle, which has what? The germinal center. Is that it for questions? Okay, now, one sec. Leen wants to tell you guys something.
Okay, hey guys. So we made this like Google Drive, inshallah it works. I added a what's it called? I added a OSPE prep Anki deck that we had from last year, and it helped us a lot in preparing for OSPE. Inshallah, it's like relevant to your material. And I also added Paul mock OSPE questions from last year. And there's also like a PDF with all the morphology for heme, with all the pictures and everything for all the morphology that you need to know, inshallah. If I find more resources, like while I'm looking through everything, inshallah, I'll add more. And thank you guys so much. We're finally done, alhamdulillah. I genuinely want to wish you guys the utmost luck. Don't be afraid, طيب, of the OSPE. Trust me, I swear to God, and it's very direct. It's just identification and functional. Identification and functional. I know it's not the same mock that was sent in the group chat. This was our mock from last year. But it's generally identification, functional, okay? This is like the basis of OSPE. Don't go too much into detail. And always refer back to your slides, of course. And also, guys, one more thing. They, not in FND, but in other blocks, they included embryo in our OSPE. Like, they were like, what is the origin of this structure? I have no idea if they're going to do that for FND. I have not seen that yet. But we never know, because we never expected embryo in ours. So please just know your embryo well from your lectures, from Dr. Paul's lectures. And yeah, I'm Leen Alfadhel, and I wish you guys luck with
And that was Mohamed, Abdulrahim. We wish you guys the best of luck for your exam, inshallah. And one more thing that I want you guys to know, you guys, when you solve a question and go to the question after it, you can't go back. So make sure you're sure of your answer before you move on. And whatever answer you put in the question before that, just forget it, okay? And good luck. That's it. Bye, guys. Have inshallah, it's a good exam. You guys got this.